Tarehe 4 mwezi wa pili mwaka 2024. Matumaini yangu kwamba umzima popote pale ulipo katika kaunti zote 47. Ni siku ya kikao, siku ambayo ndani ya runinga hii ya TV47 tunalitupia jicho swala linalohusiana na saratani, mzigo wake kwa wananchi wa taifa hili la Kenya, maswali ambayo yatakuwa yakiulizwa sawa na majibu yake, na kikao maalum ambacho kitakuwa kikiendelezwa na wale ambao ni wanahabari wetu mahiri, Alela, Joash, Onsare, Sheilar, Chelangat, wote kwa pamoja kwako kuhakikisha kwamba unayafahamu haya na mengine mengi. Lakini kwa sasa haya ndiyo yaliyomo. Baadhi ya taarifa tulizokuandalia katika upeo wa TV47. Wakuwa wanamgambo wa Al-Shabaab katika kaunti ya Mandera wamepatikana.
Hawa machifu lazima warudi nyumbani, na hawa wakora na wagaidi na wahuni tutapambana na wao.
Taharuki ya tanda katika migodi ya dhahabu ya Kakamega katika kijiji cha Machilifu, Musenu, eneo bunge la Shinyalu, baada ya wachimbaji migodi 20 kufunikwa na mchanga wakiwa timboni.
Wenye wako ndani tunaongea nao, wanasema wako salama, ndio tunapambana tuone jinsi tutaokoa ndani.
Na aliyekuwa naibu wa rais Rigathi Gachagua sasa asema kuwa alidinda kuchukua hongo ya shilingi bilioni 2 ili kujiuzulu kutoka afisini.
Because alikuwa ameniambia wewe jiuzulu nikupatie bilioni 2 uende nyumbani, uende upumzike.
Nachukua nafasi hii kukukaribisha popote pale ulipo katika taifa hili la Kenya. Kutoka hapa studioni, jina langu ni Elizabeth Mutuku, kwenye meza ya lugha ishara yupo Catherine Simaloi. Lakini kwa sasa na kuvusha moja kwa moja hadi ukumbi wa shule ama chuo kikuu cha Nairobi, ambapo mwanahabari wetu Joash Onsare atakuwa akikuelekeza mengi katika taarifa hizi. Joash, kazi kwako.
Na shukran sana Elizabeth Mutuku, kitujia mubashara kutoka makao yetu ya utangazaji hapa jijini Nairobi. Mtazamaji, tunakujia mubashara kutoka ukumbi huu wa Chandaria katika chuo kikuu cha Nairobi ili kuweza kukuletea mazungumzo maalum, ikikumbukwa kwamba siku ya leo ikiwa ni tarehe 4 mwezi Februari mwaka 2025 ni siku ya kuadhimisha saratani. Kikubwa hapa tukiangazia hamasisho dhidi ya kukabiliana na saratani humu nchini, huku tukiangazia masuala tumbi nzima, na vile vile tutakuwa na wageni ndani ya studio hapa katika eneo hili la Chandaria ili tukuweke sawa ni kipi hiki ambacho unafaa kukifahamu kuhusiana na saratani, na je, ukipimwa mapema utapata matibabu. Masuala hayo yote tutakuwa tunayapata papa hapa kutoka eneo hili la chuo kikuu cha Nairobi katika ukumbi huu wa Chandaria. Wanakwetu wananiita Joash Onsare, siko peke yangu, niko na wenzangu.
Na mie Joash, wanakwetu wananiita Linda Alela. Karibuni sana. And as Joash says, as we get to celebrate World Cancer Day, it is crucial that we are part and parcel of this conversation. Why? Because we all have at some point in time experienced the cancer burden. It could be a family member, it could be you, it could be a friend, your mother, your father, and all that. And therefore, we must join hands to get to this conversation. And as we talk about the cancer burden in the country, our message tonight will be on the question of hope, that indeed there is hope, and we'll be engaging specialists, oncologists, we'll be engaging cancer survivors, we will talk to community health workers, we will talk to ourselves just to get to know what it is that we do in our respective places to ensure that we deal with the cancer burden in the country. We also have done lots of statistics across and also spoken to people at various cadres just to get to understand what their experiences have been. And indeed, it is going to be an important conversation that begins right away, of course, right after news, and goes all the way to 11 p.m. You do not want to miss out on this. We'll be telling you how you get to engage with us. But for now, of course, I'll be sitting on this side with the panelists alongside Joash Onsare. But equally, we have our colleague on the other end who will be sitting with the people or the audience on the other side. Sheilar, over to you.
Indeed, Linda Alela, cancer has tested the resilience of families, our health systems, as well as the communities. And tonight, we get to hear from an audience who have undergone and been able to confront these realities of the harsh reality of cancer. And so the third edition of Kikao on TV47 begins now with a day's coverage of the news. Over to you, Joash Onsare.
Nam, shukran sana Sheilar Chelangat na mwenzangu Linda Alela. Mtazamaji, unaposubiri mazungumzo haya ni muhimu kabisa uweze kupata swali la leo. Na je, tunakuuliza, je, mzigo wa saratani umekuathiri vipi? Mzigo wa saratani umekuathiri vipi? Tuma maoni yako, na vile vile tutakuwa tunachangamkia wakati huo ukifika wa kipindi. Tutakuwa tunakujia kwa lisali 4 kukufahamisha, kukuelimisha ili uweze kumakinika kuhusiana na ugonjwa kuu wa saratani. Mtazamaji, hivi sasa tuzamie taarifa za siku ili tuzidi kukufahamisha zaidi, na ni kwamba Rais William Ruto amekemea vikali utekaji nyara wa machifu 5 katika eneo la Elwak katika kaunti ya Mandera. Rais William Ruto akiwa amezuru katika eneo hilo amesema kwamba hivi sasa maafisa wa usalama wanafaa kujukumika kuhakikisha wametia jitihada kuhakikisha machifu hao ambao wanakisiwa kutekwa nyara na wanamgambo wa kundi la Al-Shabaab wanarejeshwa humu nchini. Mwandishi wetu Samira Mohamed na taarifa kamili.
Kufuatia kitendawili cha tukio la utekaji nyara kwa machifu 5 na watu wanaoaminika kuwa wanamgambo wa Al-Shabaab katika eneo la Wargadud, kaunti ya Mandera, Rais William Ruto katika ziara yake kaskazini mashariki mwa nchi amewaonya vikali wanamgambo wa Al-Shabaab, akisema chuma chao kimotoni.
Tunapigana na wahuni na wakora na wahalifu pamoja na magaidi, na kwa sababu hawa magaidi tumewalemea jana kwa sababu ya kutaka kulete hali ya hofu sehemu hii, ati walienda wakashika machifu wetu.
Rais Ruto akiapa kukabiliana na wanamgambo hawa ameahidi kuhakikisha machifu hawa 5 wamerudi nyumbani wakiwa hai.
I want to promise the people of Mandera, hawa machief lazima warudi nyumbani, na hawa wakora na wagaidi na wahuni tutapambana na wao. Nimekuja na Deputy Inspector General wa polisi yuko hapa, Bwana Masengeli.
Kufuatia tukio hilo ambalo limeanikiza hali ya taharuki katika kaunti ya Mandera, Rais Ruto ameapa kukabiliana na wanamgambo hawa na kuhakikisha usalama umeimarishwa maeneo ya kaskazini mashariki mwa nchi. Aidha, Rais Ruto amedai kuwa taifa la Kenya halitawapa wanamgambo hawa nafasi yoyote ya kuvuruga usalama wa taifa la Kenya.
Na Masengeli nishamueleza ya kwamba juu chini, kulia kushoto, mbele na nyuma, east or west, mpaka mambo haya yatatuliwe, kwa sababu we have significantly downgraded the ability of the Al-Shabaab to unleash violence to the people of northern Kenya, and we will not stop at anything until we make sure northern Kenya is safe like any other part of the Republic of Kenya.
Ruto amedai kuwa wanamgambo hawa waliwateka machifu hawa ili kueneza hali ya taharuki katika eneo hilo katika juhudi za kusitisha ziara yake katika eneo la kaskazini mashariki. Machifu hawa 5 wanadaiwa kutekwa nyara wakiwa katika safari ya kikazi katika eneo la Wargadud kuelekea eneo la Elwak kwa mkutano wa kupanga ziara ya Rais William Ruto katika eneo hilo.
Walikuwa wanafikiria ya kwamba wakifanya hiyo maneno walifanya jana, ati ndio nisikuje hapa. Mimi sio ati nimekuja Mandera, nimekuja na Mandera na mimi nalala Mandera, na ikizidi naweza kulala tena, kwa sababu hapa ni Kenya.
Machifu hawa ni Mohamed Adawa, Mohamed Hassan Kulmia, Abdi Hassan Surei, Mohamed Nur Chache na Ibrahim Gabau, ambao wanasemekana walitekwa nyara wakielekea katika shughuli za serikali.
Suspected Al-Shabaab militants mounted an ambush on unsuspecting road users at that particular space, and they got a vehicle that was carrying some chiefs, 5 of them, members of the National Government Administration, who were on their way to Elwak here for a meeting.
Aidha, Rais Ruto anatarajiwa kuendelea na ziara yake katika eneo la kaskazini mashariki ambapo siku ya Jumatano anatarajiwa kuzuru eneo la Wajir. Samira Mohamed, runinga ya TV47, Nairobi.
Na shukran sana Samira Mohamed kwa taarifa hiyo. Na mtazamaji, tunaendelea kukujuza na ni kwamba aliyekuwa naibu wa rais Rigathi Gachagua amefichua sababu za kuondolewa kwake madarakani, akidai kwamba Rais William Ruto alimwahidi kitita cha shilingi bilioni 2 ili ajiuzulu na kuanza maisha mapya mbali na serikali. Akizungumza mapema leo na vituo vya redio kutoka magharibi ya nchi, amefichua zaidi kwamba rais alimhakikishia kwamba ataendelea kupata mshahara wake, anavyoarifu Mike Kagwango.
Masaibu ya aliyekuwa naibu wa rais Rigathi Gachagua na Rais William Ruto bado yanaendelea kutokota. Kwa mara nyingine tena, Gachagua amefichua siri za ndani za yaliyojiri kabla ya kuondolewa afisini mwaka jana, kufuatia kuvunjika kwa uhusiano wake na Rais Ruto.
Hakuna mtu anaweza kuunda serikali peke yake.
Akizungumza wakati wa mahojiano na vituo vya redio vya magharibi mwa nchi mapema hii leo, mbunge huyo wa zamani wa Mathira amesema katika juhudi za kutuliza hali ilivyokuwa na kumpa nafasi ya kuwania kiti cha kisiasa siku zijazo, Rais Ruto alimpa shilingi bilioni 2 ambazo alizikataa.
Na mimi ningesikiza vile rais alikuwa ananiambia nijiuzuru, because alikuwa ameniambia wewe jiuzuru nikupatie bilioni 2 uende nyumbani, uende upumzike, fanya mambo yako, kuwe na security, kuwe na mshahara na unaweza simama siku nyingine. Sasa nikajiuliza, yule anakupangia mabaya anaweza kukupatia suluhisho ya vile utaishi?
Huku akijieleza kama kiongozi asiyejipenda na ambaye hana hamu ya kutafuta wadhifa wowote wa kisiasa, amesisitiza kuwa baadhi ya wabunge waliomuunga mkono walimtia moyo kujiuzulu ili apate nafasi ya kugombea nafasi hiyo siku zijazo.
Mimi sijipendi. Hata wabunge ya kwangu wengi sana wale wananiunga mkono walikuja kuniona kuniambia wewe jiuzuru ndio upate nafasi ya kusimama. Nikasema hiyo ni kujipenda, sio lazima mimi nisimame, sio lazima niongoze. Mimi lazima nijitolee, nitetee wa Kenya na ukweli ujulikane.
Licha ya kuunga mkono maandamano ya vijana wa Gen Z walipinga mswada wa fedha 2024 na ushuru wa juu nchini, Gachagua amekanusha madai kuwa yeye ndiye mwanzilishi wa wimbi la maandamano dhidi ya serikali yaliyofanyika mwaka jana.
Mimi si kuongoza Gen Z na si kutoa pesa, lakini hao ni watoto wazuri. Kama wangenikubali niwe mkubwa wao ningefurahi sana. Ningekuwa na umaarufu kubwa sana. Kwa sababu Gen Z ndio wataamua hii Kenya nani ataongoza. Ile force iko na Gen Z ni kali sana.
Katika juhudi zake za kupigia debe eneo la magharibi, ameliomba eneo la Mulembe kuungana na kubuni vuguvugu lenye nguvu pamoja na eneo lake la Mlima Kenya, linaloaminika kuwa eneo tajiri zaidi kwa kura za urais. Hivi majuzi, Gachagua ameungana na viongozi wa eneo la magharibi akiwemo kiongozi wa chama cha DAPK Eugene Wamalwa, gavana wa Trans Nzoia George Natembeya na Cleophas Malala katika juhudi zake za kuvuruga msingi wa Rais Ruto. Mike Kagwango, TV47, Nairobi.
Tuangazie taarifa nyingine, na ni kwamba Rais William Ruto amesema serikali itafutilia mbali sera ya kuwapiga msasa wakazi wa kaskazini mashariki ya Kenya kabla ya kupewa vitambulisho, akitaja sheria hiyo kama ya ubaguzi. Rais alisema hatua hiyo ni mojawapo ya hatua zake kuunganisha Kenya bila kuangazia maeneo. Mwandishi wetu wa masuala ya kisiasa Polo Kamau na taarifa kwa kina.
Wangwana wa Mandera, hamjambo?
Ni afueni kwa wakazi wa mashariki kaskazini mwa Kenya baada ya Rais William Ruto aliyeanza ziara yake rasmi ya maendeleo katika eneo hilo kusema kuwa serikali itafutilia mbali sheria ya kuwapiga msasa wenyeji kabla ya kupewa vitambulisho, akitaja sheria hiyo kama ya kuwafedhehesha.
Children of Northern Kenya are not treated differently from the children of other parts of Kenya. Na ndio kesho mimi niko na ceremony kubwa ya kuondoa once and for all ile maneno ya vetting ambayo ilikuwa inagandamiza watu wa Northern Kenya.
Rais akitaja hatua hiyo kama mojawapo ya mbinu zake kuunganisha Kenya na ugavi sawa wa maendeleo.
Na nawauliza viongozi wa Kenya wote, jameni, tuungane, tushirikiane. Ya muhimu sio uchaguzi wa 2027. Ya umuhimu sasa ni mpango ya transformation ya Kenya. Kama hawafanyi hiyo, wanasema nani yako na kazi, nani hana kazi. Nani yako na payslip, nani hana payslip.
Tunakupongeza na tunakuunga mkono kwa sababu Mandera ni Kenya na lazima ipate haki yake kama sehemu moja ya Kenya.
Viongozi katika eneo hilo wakikaribisha msimamo wa rais dhidi ya sheria hiyo ambayo imekuwa ikitumika tangu Kenya kupata uhuru kwa wakazi wa kaskazini mashariki, na kuapa kuwa eneo hilo litampigia Ruto debe mwaka 2027.
Umesema mtoto Msomali, mtoto Mborana, mtoto Mturkana, mtoto Mkamba, mtoto Mkalenjin, wote wawe sawa wakitaka kipande, birth certificate na passport. Your Excellency, that alone is so important to the people of Northern Kenya.
Reset back to normal. Reset back to normal. Vile ndugu yangu Duale amesema, viti za chini watu wanaweza wania, kiti ya president debe ni moja, na hiyo ni ahadi tunatoa mbele ya jamii yetu ya Mandera. Mandera ama gani?
Kuhusu miradi ya maendeleo, Rais Ruto alisema barabara ya Isiolo hadi Mandera yenye urefu wa kilomita 750 ili kuunganisha maeneo ya kaskazini mwa nchi na sehemu zingine. Apol Kamau, TV47.
Tuangazie masuala ya afya, na ni kwamba waziri wa afya Deborah Barasa kwa mara nyingine amekiri kuwa mfumo wa bima mpya ya afya wa SHA unakumbwa na changamoto hususan za kiufundi. Akizungumza akiwa katika eneo la Nanyuki, kaunti ya Laikipia, waziri Barasa hata hivyo amesema kuwa tayari wizara ya afya imenunua server mpya ili kutatua swala la mtandao wa SHA kukwama mara kwa mara. Waziri Barasa wakati huo huo amewataka Wakenya kuendelea kujitokeza na kujisajili kwa SHA, kwani ndio suluhu ya kudumu ya matatizo yao ya kusaka huduma za afya.
Are working endlessly. My team and I, the Social Health Authority, the Digital Health Agency, among others, to ensure that Taifa Care is going to be implemented countrywide, and we'll have the fruits, people seeing the benefits of Taifa Care. So far, we've had more than 500,000 Kenyans having benefited. We've been able to pay various healthcare facilities that have again provided health services, and so we are deliberating with the Tobacco Board to ensure that there are funds that are allocated to manage this. Equally, we look at rehabilitation and how the people can be rehabilitated and again integrated into the community so that they can continue with their lives.
We are looking forward to having the implementation done as expeditiously as much as possible, and Madam Waziri has already given that direction, that this has been in the law but it has not been done in the past, and most of the people who would want to access these rehabilitation centers have had to go to privately run rehabilitation centers, which are very, very expensive. It's a very expensive exercise, and it takes a lot from the pocket of the people who are able to access.
Tuangazie taarifa ya tanzia, na ni kwamba watu 18 wameokolewa baada ya kufunikwa katika migodi ya maeneo ya Museno, kaunti ya Kakamega, na 2 ambao walikuwa wamekwama wakipatikana wakiwa wamefariki dunia, anavyoarifu mwanahabari wetu Violet Auma kutoka kaunti hiyo ya Kakamega.
Hali ya wasiwasi na taharuki imeshuhudiwa katika kijiji cha Machlif Museno, eneo bunge la Shinyalu, kaunti ya Kakamega, kufuatia mkasa wa jana ambapo wachimbaji migodi 20 walifunikwa na mchanga wakiwa kazini. Watu 8 waliokolewa usiku wa kuamkia leo, huku wengine 10 wakiokolewa katika mgodi huo na kukimbizwa katika hospitali ya rufaa ya Kakamega.
Kuna wale ambao wametolewa na wetu baada hatujafahamu kumuona. Kwa hivyo hatujui
nini kinaendelea kule ndani.
Naibu mwenyekiti wa wachimba madini kitaifa Patrick Ligami amesema vikosi vya uokoaji vimelazimika kutumia mashine pamoja na kupampu oksijeni ndani ya mgodi huo ili kuwaokoa wachimbaji wawili waliosalia timboni. Mildred Isindu ni mke wa mmoja wa wachimbaji ambao bado wamo timboni.
Venye tulikaa asubuhi ikafika, watu wameweza kuondolewa hapo, watu wameondolewa hapo watu 10. Alafu mimi nikangoja mzee, nione mzee, si kumuona. So nimehuzunika sana, ni kwamba mzee ameweza kuondoka. So nimehurumika sana, muniombee.
Sio mara ya kwanza mikasa kama hii kutokea katika migodi ya Kakamega. Mnamo mwaka 2019, mkasa kama huu ulitokea katika mgodi wa Rosterman na kusababisha vifo vya wachimbaji zaidi ya 10. Aidha, mwaka 2018 mgodi mwingine katika eneo bunge la Ikolomani ulisababisha vifo vya wachimbaji wengine 6.
Serikali isaidia watoto vifaa kwa sababu hii kuchimba gold kumeokoa wananchi, ile wizi ilikuwa inaendelea kubwa na kukatakata watu.
Wakazi eneo hili wameitaka serikali ya kaunti na ile ya kitaifa kutoa mafunzo na vifaa kwa wachimbaji wadogo ili kuzuia ajali kama hizi ambazo zimekuwa zikitokea mara kwa mara.
Inafaa wakuje wapeane safety na PPEs. Hiyo itasaidia vijana wetu katika kuweza kujiokoa kwa sehemu zingine. Alafu wapewe training.
If the county government cannot bring the immediate rescue to our people, that's very wrong.
We wish that the national government was functioning. Hatuoni support ya national government sahi. Hatuoni support ya county government sahi. Kitu yenye tunaona tu ni kupitisha hapa ambulance. Ambulance is after the fact. What we need here is the fire brigade. Iwe imeangusha hiyo mashini yao mpaka chini. It has the capacity to go far deep. It pull people out.
Watu 8 kati ya 18 waliokuwa wakipokea matibabu katika hospitali ya Kakamega wameruhusiwa kwenda nyumbani kujumuika na familia zao. Kadri operesheni za uokoaji zinavyoendelea katika Machliff, Mildred Isindu ana matumaini kwamba mumewe atatoka akiwa hai na kujumuika na familia yake. Violet Auma, TV47.
Na mtazamaji, mili ya watu wawili ambao walikuwa wamekwama katika migodi hiyo vilevile imeweza kuondolewa, kumaanisha kwamba wamepatikana wakiwa wamefariki. Tuangazie taarifa nyingine, na ni kwamba wazee ama baraza la wazee wa Njuri Njeke limemtaka waziri wa huduma ya umma Justin Muturi kukoma kuikashifu serikali na badala yake kuwa na kikao na rais kutafuta mwafaka, wakitaka Rais William Ruto kuingilia kati swala la kumtaka Muturi ajiuzulu pamoja na Jaji Mkuu Martha Koome. Kulingana na Adrian Aruyaru, kiongozi wa wazee wa Njuri Njeke, swala la kuwataka viongozi hao kujiuzulu katika nyadhifa zao za uongozi halina msingi wowote, ila linakandamiza eneo la Mlima Kenya Mashariki.
Rundi kwa deputy Kithure Kindiki, ndugu yako, muongee, na kama kuna shinda mbali, because wewe uko kwa the top 22 wale ambao waweza fikia rais. Keti kama vile unasema, kama ni ukweli unasema ulienda kuongea na rais. Kama uliongea na rais, si uende hata sahi uongee na yeye.
To engage Meru County because his main critical issue it is on how to bring all the people together, because at the end of the day
that is serving. If I see that narrative, the narrative of Muturi is the same as the narrative of Gachagua when they talk about Haji, the niece DG. So it's better that they have evidence without technically issuing threats out there without concretized evidence, so as to prove to Kenyans that this are real. I think the president has made a commitment that is going to ensure there will be no abduction. So I believe the investigation agencies are doing their bit to ensure that this is done.
Tuangazie taarifa nyingine, na ni kwamba tume ya utekelezaji wa haki CAG imeshtumu idara ya mahakama kwa kukosa kuwajibika katika kushughulikia malalamiko yanayotolewa dhidi yake na wananchi. CAG sasa inasema kwamba idara ya mahakama imefeli pakubwa katika kusuluhisha malalamiko dhidi ya mahakama. Sasa tume hiyo imeitaka mahakama kuwasilisha ripoti ya kutatua malalamiko hayo chini ya siku 21. Tume ya CAG inasema kwamba kati ya malalamiko 700 ambayo yametolewa, 398 bado hayajatatuliwa. 302 pekee ndio yametatuliwa. Malalamiko haya yanahusu kuchelewa kwa kutoa maamuzi kotini, uzembe, kutowajibika kwa maafisa wake na kutotoa haki inayofaa, pamoja na ufisadi. Na mtazamaji, hivi sasa tuzamie taarifa za michezo, na ni kwamba michuano ya kufuzu mashindano ya mchezo wa kikapu barani Afrika ya FIBA ilishuhudia kina dada wa Sudan Kusini wakiwabwaga Kenya katika mechi iliyoandaliwa leo jioni katika uwanja wa Hassan Mustafa nchini Misri. Haya yanajiri baada ya timu ya Uganda kupata alama 78 kwa 56 katika mchuano wao wa kwanza wa michuano hii iliyoandaliwa hapo jana. Kikosi hiki cha Kenya sasa kitachuana na Burundi hapo kesho kabla ya kumenyana na Misri Ijumaa usiku, wakiwa na lengo la kujikatia tikiti ya kushiriki katika mashindano haya yatakayoandaliwa baadaye mwaka huu jijini Abidjan.
On an island, top of the key! And Selena Okumu have not taken care of the ball the way they were supposed to, and now when it rains, it pours! Bang, bang, bang! Breakaway layup, Reynolds.
Na mtazamaji, taarifa hiyo ndo ambayo inatutamatishia awamu ya kwanza ya taarifa za upeo wa TV47. Tukitoka mapumziko, tutakuwa tunazamia kikao ambapo tunaangazia masuala kuhusiana na saratani, na tunakuuliza ukiwa pale nyumbani, je, mzigo wa saratani umekuathiri vipi? Je, mzigo wa saratani umekuathiri vipi? Hivyo basi endelea kuganda nasi, tukirejea tutakuwa tunazamia swala hilo kwa kina.
Are you ready to elevate your business game?
As long as you're earning something, there's always that opportunity to save. And you start with where you are.
Kama wewe ni mfanyabiashara, huwezi kaa bure, unajipanga taratibu vile inavyofaa.
Join us each week as we dive into the stories of the world's most driven entrepreneurs.
When you pay attention to detail, you get luxury items.
The Grind, where business meets brilliance. Tune in every Monday at 7:30 p.m. because your business deserves the best.
Hey there friends, welcome to Kids on the Block, where fun and imagination come alive. We dive into magical world filled with exciting adventures and awesome friends.
What position were you in?
I was number 2.
What position were you?
Number 1.
He decided to cross the bridge by his house and look for food on the other side.
We're going to do half cup of chocolate chips, and the other one, we're going to do half cup of the blueberries.
So, grab your imagination hats and get ready to explore with us. Join us every Saturday at 9 a.m. for new friends, amazing stories, and tons of laughter.
Join us as we explore the journeys of those who defy the odds and break barriers. We dive deep into the stories of triumph.
Sometimes when parenting a child with a special need or whatever disability, family life becomes a bit complicated and you may end up raising the child on your own.
Here, we inspire.
I have a farm which one we showcase with other dyslexic youths and autism how to farm.
Motivate.
It's never easy, but what we do, the best thing is to work with another parent who has an elder child than yours.
And break through the barriers one story at a time. Push your boundaries beyond the limit. Saturdays at 8 p.m.
Jiunge nasi tunapoangazia safari za viongozi bora. Kutoka kwa ushindi mkubwa hadi masomo magumu.
Wakati wetu kwamba wasichana si wa kusoma, ni wa kuolewa, ng'ombe ipatikane, wazazi wakuwe watajiri.
Tunashughulikia yote.
I wish I were a better investor.
My parents taught me how to look for things for myself.
Tazama Mfahamu Kiongozi, ambapo kila kipindi kimejaa maarifa, mikakati na hadithi za kukuza azma yako.
For me to succeed, I have to fight.
Kila Alhamisi saa 1:30.
Are you ready to elevate your business game?
As long as you're earning something, there's always that opportunity to save. And you start with where you are.
Kama wewe ni mfanyabiashara, huwezi kaa bure, unajipanga taratibu vile inavyofaa.
Join us each week as we dive into the stories of the world's most driven entrepreneurs.
When you pay attention to detail, you get luxury items.
The Grind, where business meets brilliance. Tune in every Monday at 7:30 p.m. because your business deserves the best.
Hey there, friends. Welcome to Kids on the Block, where fun and imagination come alive. We dive into magical world filled with exciting adventures and awesome friends.
What position were you in?
I was number 2.
What position were you?
Number 1.
He decided to cross the bridge by his house and look for food on the other side.
We're going to do half cup of chocolate chips, and the other one, we're going to do half cup of the blueberries.
So, grab your imagination hats and get ready to explore with us. Join us every Saturday at 9 a.m. for new friends, amazing stories, and tons of laughter.
Join us as we explore the journeys of those who defy the odds and break barriers. We dive deep into the stories of triumph.
Sometimes when parenting a child with a special need or whatever disability, family life becomes a bit complicated and you may end up raising the child on your own.
Here, we inspire.
I have a farm which one we showcase with other dyslexic youths and autism how to farm.
Motivate.
It's never easy, but what we do, the best thing is to work with another parent who has an elder child than yours.
And break through the barriers one story at a time. Push your boundaries beyond the limit. Saturdays at 8 p.m.
Mtazamaji, ndo namna hiyo tunaanza kipindi cha Kikao kutoka ukumbi huu wa Chandari katika chuo kikuu cha Nairobi. Kikubwa siku ya leo tukiangazia saratani. Kumbukwe kwamba kila tarehe 4 mwezi Februari mwaka 2025 siku hii tunaadhimisha siku hiyo ya saratani kwa kukuhamasisha na vile vile kukueleza ni kipi hiki ambacho unafaa kukifahamu kuhusiana na saratani. Saratani ni ugonjwa ambao umekuwa mzigo kwa watu wengi na vile vile hata kwa taifa na mataifa mengine. Na siku ya leo mtazamaji, tunazamia hilo kwa kina kwa sababu tuko na wataalam na tuko na swali kwako ukiwa pale nyumbani ukitutazama. Ingia katika mitandao yetu ya kijamii pale kwenye Facebook TV47 Kenya, kwenye akaunti yetu ya X unatupata pale TV47 News, na vile vile unaweza tuma jumbe zako, tutana maswali yako, tutakuwa tunayasoma kadri muda unavyozidi kusonga. Na swali la leo ni je, mzigo wa saratani umekuathiri vipi? Je, mzigo wa saratani umekuathiri vipi? Wanakwetu wananiita Joash Onsare, siko peke yangu, mwenzangu Sheilar Chelangat yuko katika hadhira, atakuwa anazungumza nao vile vile kukuweka sawa wana maswali yepi, wangependa kusema kipi kuhusiana na siku hii ya kuadhimisha saratani, kikubwa kikiwa ni kuhamasisha. Na vile vile nina mwenzangu ambaye atakuwa anatambulisha wageni wetu, Linda Alela.
Asante sana. Wakwetu tunasema wananiita Linda Alela, sio eh? And yes, it's a conversation that is open. We speak both in Swahili as well as English. The bottom line is for us to understand just how deep the cancer burden is in the country. But of importance is that we want to remind you that indeed there is hope. Why I say so is because I have had a conversation with every other person that is, represented in this house or in this room today, in this auditorium, different stakeholders, and indeed in unison we all agree that there is hope. So before we get to understand where this hope comes from and what exactly then is the hope, we must discuss this. And so allow us to get to introduce the ladies and gentlemen that are seated on this side, that is the panel side, the ones that are going to help us understand some more as to where we stand as a country into this discussion of the cancer burden. I am delighted to sit right next to a representative of the ministry. I mean, once you have the ministry in the house, then you're certain that beyond discussing just how cancer is deep in the global spectrum, right here in the country, then we have answers. And so Dr. Sultani Matendechero is right next to me. He is a senior deputy director at the Ministry of Health. Asante sana Daktari for creating time to be with us this evening. I know Kenyans are eagerly waiting to hear what the stats are like and where we stand, where we're positioned when it comes to dealing with cancer, and I'm sure you are ready and set to respond to those questions. We also are delighted to have Phoebe Ongadi, who is the Executive Director, Kenya Network of Cancer Organizations. Thank you so much, Phoebe, for creating time. Equally, of course, we depend so much so on the stats that you're going to accord us and the numbers that you're going to give us as to the cancer situation in the country. Right next to Phoebe is none other than Anne Korir. Anne Korir is the head Nairobi Cancer Registry and also senior research scientist, cancer epidemiologist, that is of course under KEMRI. Research is crucial to us addressing the concerns of cancer, and so we also want to understand, are we doing it right? Are we doing it wrong? Why is it that we keep complaining about the concerns of diagnosis and all that? And right next to Anne, we have none other than Dr. Onyiro Omondi, who's a lecturer, Department of Internal Medicine, University of Nairobi. Dr. thank you so much for hosting us. Now that we are seated right here, Asante sana for creating time as well as we get to discuss some more as to the cancer burden in the country. And right next to Dr. is Professor Mansour Saleh, the chairperson, that is Department of Hematology, Oncology, Aga Khan University Hospital, right here in Nairobi. Asante sana for creating time. Asante sana. Kiswahili tuko sawa? We're good. Sawa kabisa.
Asema Swahili for sure.
Good. Asante sana. So Onsare does not get you lost, Professor.
But
thank
not
you
your
so
kind
much.
of Swahili. My level is different.
Tutafanya rahisi.
All right. And of course, last but not least, Eunice Mwende, who's a cancer survivor with a beautiful story. And that is why we say that ultimately, beyond the troubles of cancer, there is hope. Perhaps to share your story briefly so that it can kick us to the conversation.
Thank you. Thank you so much for having me. My name is Eunice Mwende Mutiso. I'm 32 years old. I was first diagnosed with breast cancer when I was 23 years, and that was in 2016. So in our family, we don't have any history of any type of cancer. So, and I'm the youngest. So having a breast cancer diagnosis was really foreign, and we didn't quite understand what it entailed. So I had a mastectomy, which is removal of the whole breast, in the same year, 2016. Later on, then I was put on medication, tamoxifen, a tablet a day for 5 years. But unfortunately, after 3 years, I got a recurrence in 2019. So at that time, the cancer had spread to my lymph nodes and one of my lungs. And now that was metastatic breast cancer, which I better know it as stage 4 breast cancer. And I was informed that it is incurable. So what we started doing with the doctors who are handling my case was more of managing it so that it doesn't spread faster. So I was on, I did chemotherapy and targeted therapy from 2019 to around 2021, 2022, and because of the financial burden, I had to stop the treatment. So from 2022 March, I had to stop active treatment, but I was doing annual, checkups, scans to just see how it was. And in 2023, around September, when I did a full body PET scan, I had a recurrence, a nodule recurrence. So while I was in the process of now resuming my treatment, I got pregnant. So I didn't resume treatment, and I opted to have the baby. So my baby is 10 weeks at the moment.
Oh, beautiful.
And I'm here to share my story. So that is basically my story.
And people will be curious, you're breastfeeding. I mean, what happens? Just paint a picture of what then after the baby. Under meds, you stop the meds, or what exactly?
Okay, I'll take you a little bit back because we are also looking at the heaviness of this disease. So when I was diagnosed in 2016 and I had a mastectomy, it was really challenging for me. Being a young woman and having one breast, I actually didn't want anybody to talk about it outside our family. I would get really cross when that happened. And I got into depression for quite a number of months, actually about a year and a half. And at that time, I didn't know the importance of seeking therapy because this was also not pointed out to me when I was being diagnosed. And I felt that, that is one of the things we need to really be keen on when we are being diagnosed. When patients are being diagnosed, it's important and it's key to have now, the therapy. And so I had depression, and then I came out of it and I looked at life a bit differently, and I learned how to, a different definition of beauty, not just the physical beauty. And so by the time I was being diagnosed in 2019, I had already come into terms, with the first diagnosis. But of course, no one can you can't be ready to be diagnosed with stage 4 this was a day before my 27th birthday, and my prognosis at that time was 1 year. So again, that was a big blow for me. I had just resumed university, and at that time I had to choose both diagnoses. Actually, I had to choose between school and seeking treatment. So again, I sought treatment, and I had to stop schooling, it was a bit of a tough decision because I've always wanted to pursue my degree in psychology and counseling. So that was a tough one for me, and I resumed therapy. I got into different support groups, and one of the support groups I joined is called Kilele Health Association. It's made up of cancer survivors and caregivers. So through this organization, looking at now survivorship, we were hiking together, coming together, and that is something which gave me hope in terms of seeing that there is life beyond a cancer diagnosis. So I have hiked with them. We've climbed Mount Kenya, we've climbed Mount Kilimanjaro with this prognosis, and this also shows you that again, life doesn't need to end after this. So after, and when I now got this second diagnosis, the option of having a baby, it was not in my reach anymore, because one of the things I was already advised even before starting treatment it was after starting treatment, after my second chemotherapy. That's when I realized I needed to actually ask about fertility and having children, because I didn't have any. And at that time, my oncologist, we had not discussed this, which I feel, again, it's a huge topic we need to discuss before starting treatment. So that's when I was told about, egg harvesting and seeking, just going to, check the cost of this. It was, again, beyond me. I could not even afford it. So I just continued with the treatment, knowing that the chances of me ever having a biological child were not there anymore. So having a baby is also a miracle for me, honestly. And and when I got now pregnant, as I mentioned, I was in the process of now resuming treatment. We had quite a tough conversation with my oncologist. I have to say I am blessed to have an oncologist who listens. And she told me of the pros and cons of being pregnant, the chances of the progression of this cancer if I decide to continue with having the, keeping the pregnancy. She also mentioned, told me how I would probably need to start chemotherapy while still pregnant after the first trimester. So these are some of the things I needed to consider when I was making this decision. And gladly and, gratefully, I didn't have to do treatment while I was pregnant. But again, it's something which I need to go back and continue. So in terms of breastfeeding, I am breastfeeding and I haven't resumed treatment yet, but I have to say I am really grateful that health-wise and physically I am doing well.
Congratulations for baby.
Thank
That's all I love when you go back home. All right. You've got a beautiful story, yeah?
Bila shaka na ni vizuri tukuongere kwa sababu wewe umejitokeza ikiwa ni wakati ambapo tunazungumzia masuala haya. Hongera sana kwa kujitokeza na kuwapa wale wengine wako pale nje ule mwanga wa matumaini kwamba mambo haya yanawezekana na vile vile tunaweza pambana na kupigana na saratani. Safi. Hivi sasa mtazamaji, tuangazie kingine, na hivi sasa namkaribisha Daktari Sultan Matendechero kutoka Wizara ya Afya ambaye ni katibu ama ni naibu mkurugenzi katika wizara hiyo. Daktari, najua kuna wengi wanataka kujua hali halisi ya masuala ya saratani humu nchini. Kutoka kwa wizara, tunaendeleaje katika kupambana na saratani humu nchini?
Asante sana kwa kunialika katika mazungumzo haya muhimu. Kile ambacho ningependa kusema ni kwamba kutoka kwa Wizara ya Afya tumeweka mikakati kabambe ya kuweza kushughulikia mambo ya saratani. Jinsi unavyojua, kwa Wizara ya Afya majukumu yetu, jukumu kubwa kabisa ni kuweza kuweka sera, zile policies pamoja na zile guidelines za kuweza kutibu ama kuweza kufanya ile screening. Kwa hivyo tumeweza kuweka kadhaa. Utaniruhusu nizungumze kwa Kimombo, najua huwa tunazungumza kwa Kiswahili, lakini sasa hapa naona Kiswahili kitakuwa kigumu kidogo. Kwa hivyo just to maybe name some of the policies that we've put in place to be able to guide management of cancer. We have the National Cancer Treatment Protocols that came into place in 2019. We have the National Cancer Screening Guidelines of 2024. We also have the National Cancer Control Strategy 2023 for a 5-year period up to 2027. So that's what we are now implementing. We also have a National Cancer Policy, which now is actually giving rise to most of these documents that we are talking about. That is spanning from 2019 to 2030. Now remember, our main aim is to actually be able to reduce the number of new infections by about to about a third by 2030, and we also have a breast cancer action plan, because breast cancer, as you've heard, and by the way, I really get encouraged when I hear stories like Mwende's story, which really give a lot of hope to many of the people, victims, who are affected by this very big problem. So we have an action plan just geared towards breast cancer, running between 2021 and 2025. So maybe just to say that actually cancer is one of the biggest public health problems in Kenya. Actually it ranks very highly. When you combine all the infectious diseases, actually now it comes a close third, because when you do all the infectious diseases, they come top. Then we have the cardiovascular diseases, and then we have cancer. So it is a very big problem, claiming thousands of lives every year. I know that we will I'll give an opportunity for others to put in the statistics, but it is a very, very big problem. We are having very many new cases, very many unacceptably high number of deaths globally, within the Africa region, within Kenya. It is something that we really have to pay a lot of attention to. Now, just so that I can also conclude and give some time to my other panelists, fellow panelists, to say something. What I'd just like to say is that we have now started rolling out a very big policy in the country around, very ambitious, by the way, to try and make sure that we are rolling out universal health coverage. And what we mean by universal health coverage is that each and every Kenyan who, is able to access high quality care, medical care, at an affordable cost. Yeah? And that is a very ambitious plan, because I'm saying this on this World Cancer Day, because the cost of treating cancer is unaffordable to most people. So that becomes one of the specific areas that we are targeting, to say even those who require lots and lots of money to be able to manage cancer then should be able to get treatment. But at the bottom line of this policy, we are saying that we want to prevent a situation where people will require to use a lot of money. So we are putting a lot of emphasis on health promotion and disease prevention, so that we minimize the numbers of people who need treatment, that expensive treatment. We are focusing more on screening, so that we detect cancer early, and then we are able to manage. Because when we get it early, and I know a lot of the panelists here will really expand on that, then even the chances of treatment are increased, as opposed to when we now get it much later, then we find that it becomes more difficult for us to achieve good outcomes in terms of treatment. No. So as a government, we are on the front line to ensure that we actually put this problem under control, so that we reduce the numbers and we have much more effective outcomes in terms of detection and treatment.
No.
Thank you.
Shukran sana Daktari Sultani Matendechero, ambaye ni naibu mkurugenzi mkuu kutoka Wizara ya Afya. Na mtazamaji, hivi sasa tunaendelea pia na maswali kuweza kupata washikadau wanasemaje na vile vile wataalam, na tungependa kujua, nikizungumza na daktari ambaye ni Daktari Mansur Saleh. Hivi sasa tunazungumzia aina tofauti za saratani. Labda ni saratani zipi ambazo zimeonekana kuwa hatari zaidi humu nchini?
You know, I was born in Zanzibar. I used to speak Swahili very well, but you are beyond my level of comprehension. Even the ministry had to change to English, so you have to. I understood you're calling me out, but go ahead and ask me the question in English.
The most common cancers that we have, and perhaps I'll need to top up to his question as to what it is that the DG speaks of, or the Deputy DG speaks of, in relation to the possibility
of us reducing the burden in terms of treatment prices, you know, in the country? Because then this is not the first time we're discussing this, and I know we progressively get somewhere, but do you realistically think that as a country we are well positioned, first of all, to address this concern in terms of treatment and the prices that come along with that, but as well in terms of just detecting and perhaps avoiding this? Because then we're also saying that we are focusing much on preventive care more than, you know, that level where it gets to curative.
It is fair to say that the government makes policy. The people have to implement policy, and then in between we have to facilitate. We just heard to say that the care was expensive, beyond my reach. So if the government makes policy to say we will have mammography for breast cancer, colonoscopy for colon cancer, and pap smear for cervical cancer, but if it's very expensive, then that policy cannot be implemented to reduce the burden of care. But also it depends upon the population itself. What is our level of knowledge about cancer? 1 in 30 women will develop breast cancer. 1 in 35 will develop cervical cancer. 1 in 10 population, and we see here we've got about 100, 1 in 10 will die of cancer down the road. So what do we know about cancer? We know that the most common cancer in Kenya is breast cancer. The only way to detect it early is mammography. So I believe the policies of the government should allow mammography to be cheaper so that we can detect it early. And then we can prevent it, not prevent it, but at least detect it early, stage 1, stage 2. Patient can be cured and have a productive life, pay taxes. So really it benefits everybody. What about pap smear? The best way to eradicate cervical cancer is vaccination. Cervical cancer is caused by the HPV virus. We vaccinated ourselves against COVID. Otherwise, we were dying. What about cervical cancer? If we did vaccinate our children at the young age, 98% of cervical cancer would be eradicated. Well, we have not reached that stage because there's all kinds of social controversies about vaccinating against cervical cancer. So I think what we need to do as a population, look at new knowledge, to be able to really implement that knowledge, and then certainly the government can do their part to facilitate, to make these applications much cheaper, affordable for the patient who needs them the most.
All right, pretty much good. I think that brings us to the research bit. Then we'll come back to you, of course, to get to understand that element of diagnosis that you have highlighted. But basically, when we're looking at this, and the research ladies are here seated, and one would want to ask at this very point, Kebri, just how much has the government been serviced, you know, by backed up research information that is good enough to help them, first of all, come up with policies that are practical, but above everything, proceed to help implement these policies?
Thank you. So research is key in terms of cancer control, because we need to be able to come up with interventions to be able to control these malignancies. I would say that KEMRI for the longest time was more focused on infectious diseases. But of course we do research on non-communicable diseases, cancer included. One of the key things we invested in early, way back in the year 2000 about cancer was to really understand the burden, to understand what is affecting our people. So we invested in establishing a cancer registry that has been in existence for over 20 years. So we were able to tell the cancers that are prevalent in the community, which ones are going up, which ones are going down, what then would inform research or putting in more resources. So for instance, when we look at women, we have data that supports that breast cancer and cervical cancer are the two cancers that are killing our women. We have data on incidence, we have data on mortality, we have data on survival. And you realize that we are diagnosing these women at a late stage. What happens when you diagnose them at a late stage, stage 3, stage 4? It means that there are poor outcomes. Many women are dying of these diseases. So the question then should be, why are they being diagnosed late? Is it them coming to the facility late, or is it our health system that is failing them? We've also seen, of course, cancers that are also common in the men population, like prostate cancer, esophageal cancer. We are seeing colorectal cancer now coming up, both in men and women. esophageal cancer as well, very common in women. So you're having this double burden of cancers affecting the women, but overall, 40% of the cancers in women are breast and cervix. And as you've heard from Daktari, these cancers are preventable and they can be managed. We shouldn't be losing so many women to these cancers. Why? Because if we vaccinate, if we screen, then we are able to overcome cervical cancer. For breast cancer as well, if we did screening with mammography, we are able to diagnose them early and be able to treat. When you diagnose at stage 1, stage 2, survival from our research is very high. People survive 90% and above when they are diagnosed at stage 1, stage 2. But the unfortunate situation is that our data is showing that we are diagnosing them at stage 3, stage 4, when we know very well that the treatment, even as much as the doctors are trying, the treatment then become less effective. So we are doing research. Of course, there are other research beyond the surveillance that we are doing on cancer. There's lab research that looks into diagnostics. There's molecular research. There's research that looks at the genes, in relation to cancer. There's research that looks into the risk factors to isolate what are the risk factors that are really predisposing these cancers. But I want to say that funding for research is still very limited in our country. We really need to invest in research. We have not invested adequately in research, in funding research that is affecting our people. We over-rely on donor funding, and when you over-rely on donor funding, then you don't really get to be in control of the agenda. So we need government to put in funding for research so that we can be able to do more and be able to really come up with more intervention, more ways of diagnosing these cancers early, better therapeutic ways so that we can manage the cancers that are being diagnosed in the population.
We're glad that the government is here tonight, and so I hope the government is taking note. But then before you come in with Phoebe, briefly, Dr. Professor acknowledges that there's knowledge gap. Perhaps there's a concern when it comes to the question of education. Just how critical would it be in terms of enlightening the masses, the element of education? And we also understand that research goes hand in hand with that element of education. So that if we get the most and the best of data from the research that we collect, and this is not disseminated to the public for use, then it becomes useless. That if we're going to form the best of policies, at that level of the government, but this then is not known and is not consumed by the masses, it becomes a problem. How do we go about this to address the same so that we all are in tandem towards this fight?
Thank you very much. This year the theme is, I think, united in uniqueness, and listening to her story, what united in uniqueness means is that every cancer patient has a personal journey with their cancer management and just living through the cancer diagnosis. But some people have misconstrued this to mean that each patient care is now unique, but there are certain aspects of care that cannot be unique, like quality of care, Dr. Matendechero. This must be universal, and every attempt should be made to make quality care, safety of that care, access and readiness of the system to cancer care universal. And I'm glad you're saying we are rolling out universal care. Number two is about the challenges that we face as a country in this cancer journey. And one of it that you've alluded to is awareness of the population about cancer services, which is quite low. If you look at surveys that have been done in Kenya, if you look at the Kenya Health Facilities Assessment and some of the vital documents in the Ministry of Health, awareness is quite poor, and this has been one of the reasons for either late presentation to health facilities, and that means that we are diagnosing our cancer cases at an advanced stage. I think 3-4 years ago, 80% of cancer diagnosis in Kenya was at an advanced stage. But I'm glad to report that has been reducing, and one of the interventions was health education, so that people are aware of the signs and symptoms of cancer, where to get this cancer services, the need to do early diagnosis. And this is really important for the citizenry to also know where those services are. Now, there's a lot of research that is going on even at the University of Nairobi. And one challenge that we have as researchers is communication to the public, how to convert the scientific information to the public. For example, if you say the overall survival of a particular disease is 60% at 5 years, for us we understand this amongst ourselves. But the assumption we make is that the population is going to digest it the same way. So translation of scientific information to non-scientific or to lay people has been a big challenge. And I think the ministry, when you go through some of the strategic documents that the ministry is a very ambitious process for health education, reaching out to the public through primary health care, and the refurbished Social Health Act has a primary care arm, which is meant to reach 80% of the population. If you read the Kenya Health Facilities Assessment, 80% of which is level 1, 2, 3, you look at the first of all cancer services in those health facilities in terms of screening, because that is where you need to take screening services. If you bring screening services to Kenyatta National Hospital, it should be there, yes, but if there's no screening services at the health center, you expect somebody to leave a rural village in Kiambu or Murang'a or Siaya to come for cervical cancer screening at the Kenyatta National Hospital. I think you obviously see there's a big challenge to that. So with the lack of those screening services in those primary health facilities, then the population around that health facility will not get access to cancer education. So I think one thing that we need to do as scientists, we need to convert the scientific information that is, for example, at the University of Nairobi repository. It's very rich with the studies that have been done on cancer, but how this is translated so that the public can understand that when you have this symptom, for example, if you have constipation, and there is this common treatment which is H. pylori, you find everybody we see who eventually make a diagnosis of cancer, a big percentage has been treated H. pylori. And the way the population understands the H. pylori treatment, I wish they could get the same message about breast cancer screening. Because some people come and demand, I need H. pylori treatment. I wish that we can employ the same strategy that people who marketed the H. pylori kits used to educate the public, so that somebody can make a conscious decision to go to the hospital to have H. pylori treatment. If we can get that strategy so that somebody can make a conscious decision and say, I want to go and have my mammogram, I want to go and have my annual cervical screening. Thank you.
Asante sana daktari kwa kauli yako, na hivi sasa tumshirikishe Phoebe Ongadi ambaye ni mkurugenzi mkuu wa shirika la Kenco, mashirika ambayo yameletwa pamoja kuangazia masuala, na ulivyozungumzia tiba na vile vile ya saratani, ni muhimu zaidi tuweze kujua ni vipi masuala haya yanashirikishwa na mashirika haya ili kuweza kuhakikisha wagonjwa wanapata tiba kwa wakati. Phoebe, mnafanya vipi kuhakikisha mzigo huu wa tiba ya saratani unapungua?
Asante sana, nimeshukuru na nimefurahi sana kuona Wizara ya Afya karibu na mimi hapa. Najua suluhisho zangu zote za SHA nikitoka hapa nitapata majibu ambayo yametuzuia kidogo kama cancer fraternity. 30% na 50% za kesi za saratani zinaweza kuzuiliwa. Hapo ndio tuanzie kama Kenco. A third and half of cancers can be prevented. Na kwa hivyo jambo la kwanza ambalo tunafanya kama KENCO ni kufanya ile uhamasisho ama public education and awareness. Tunapata kwamba why we have late diagnosis, ama kwa nini wagonjwa wengi wanakuja wakati ambapo saratani imeenea zaidi, ni kwa vile hawajui, hawana ule ujumbe. Na niseme tu kidogo, Eunice ambaye amekaa hapa ako na taji, anafaa awe alitembea nayo, taji ya Scars to Stars. Pale KENCO pia we celebrate. So last year she won, heavily pregnant, down the L. She was able to win. I think she deserves a hand of a clap for that. So we leverage on public kuhamasisha jamii. Kitu ya pili ambayo tunafanya ni kuwa tunajaribu kutafuta zile policies ambazo zinasaidia. Vile nimesema, maneno ya SHA kwa karatasi ni mzuri sana, lakini tunataka sasa itoke kwa karatasi kuje kwenye mashinani iweze kufanyika zaidi. Pia tunafanya ile inaitwa kwamba most of wanachama wengi wa KENCO ama most of KENCO members wana ile inaitwa patient led. Kwa hivyo ile patient led tukitembea na wagonjwa pamoja na zile stories zao ama patient stories, acha tuniongee na kimombo. We have the patient led organization. So when we have those, we also do a lot of psychosocial support. Like Eunice and many other people told you, when they're in a group, when talk patients together and they share their stories together, it's a bit different. So KENCO also, together with our membership organizations, we also participate in the enactment of the 2012 Cancer Prevention and Control Act, and that is what brought up the National Cancer Institute that is currently doing the implementation of what was Kurugenzi said the strategic plan for 2023-2027. So hayo ndio maneno, a few of the interventions that we are doing as a group and also as individuals.
Shukran sana. Hivi sasa tumshirikishe mwenzetu mtazamaji ambaye ni Sheilar Chelangat ambaye anatangamana na hadhira. Sheilar, hadhira inasemaje kuhusiana na swala hili? Tusikie hisia zao pia.
Indeed, Joash, Onsare, we are listening to the experts speak about, sensitization, being that today was World Cancer Day. So it's all about sensitization, uhamasisho, that is what I have heard. But does this public, does this audience really understand what it means by sensitization? Do they understand? Are they aware of some of the signs and symptoms? Are they aware of some of this research? And so with me here is Paul Nganga. You are a patient who is undergoing treatment. What are some of the signs and symptoms that perhaps you noted before going in for treatment and seeking for that diagnosis?
Thank you very much. For the first time, what I noticed in my body was hemorrhoids. But I didn't know that they'll come with cancer. Then I went to Kiambu Level 5 for treatment. After surgery, that's when the doctor did the biopsy. I was sent to Aga Khan Medical. They say that I have those symptoms of cancer. Then I was referred to KNH for treatment, but I was sent to SOPC, not to oncology. Then after that, they did physical examination for, I'll try to be brief because of the time. They did physical examination and told me that they don't see any problem that I have. So I was sent home and told whenever that I have any problem to go back to KNH. Then I stayed for about 3 years with a lot of pain, and I was taking drugs for painkiller. I went to Mama Lucy again for treatment. I went to Kenyatta. They told me go to Mama Lucy. You cannot be treated here without referral letter. So when I went to Mama Lucy, they did the operation again and told me that they have found what they were not expecting. So they told me to bring all the papers that I obtained from Kiambu Level 5 and all the CT scan and MRI colonoscopies that I got from German hospital. Then when he compared them, he told me that the problem that they have seen, it is similar. So I was sent to oncology at KNH.
And so far, as in this journey of your treatment, what would you say is that challenge that you have faced majorly?
Concerning treatment?
Yes, concerning treatment.
Okay, concerning treatment, the major problem is when you go for MRI, colonoscopy, all those, the insurance cover used to cover almost 3/4. It was not able to cover everything. Then when you go to KNH, for consultation, you have to pay cash. So the insurance cover does not pay for cash for consultation. And even when you go for blood works, you have to pay cash. But for the doctors there, they have time for you. They listen to you. They are very caring. But again, the bigger challenge that we have there is that after seeing the doctor, when you are sent for chemo, you find there are no drugs. So you go to another hospital.
All right, those are some of the challenges and the realities of cancer, and that we are hearing from a patient who is currently undergoing treatment. But it's not just about now the treatment. There are some who have undergone the diagnosis but are yet to start the treatment. So why is that? Let's get to hear from Jacqueline. Hujambo, labda utueleze tu story yako. Uliweza kujuaje una kansa na mbona kufikia sasa hujaanza treatment yako?
Kitu naweza sema ni venye nilijua niko na kansa. Sikujua, nilienda nilikuwa na infections zilikuwa zinanisumbua sana, so nikaamua kwenda hospitali niangalie kwa nini hizi infections zinanisumbua. Wakiniangalia wanaona ni UTI, kila time UTI. So nikaamua kwenda kwa hospitali zingine na ingine, nikiangaliwa na niambia tu ni infection, wananipatia dawa za kuinsert na za kumeza. So niliendelea tu hivyo, nikaamua niende Bagavi nifanye testi zote. Nikaenda Bagavi nikafanya test, nikasema wacha nifanye kila kitu. Nikafanya pap smear, nikafanya test za mkojo, kila kitu. So nikaambiwa mbona ulikaa hivyo mpaka hii ugonjwa imeenda mbali hivyo. So ile kitu ilikuwa imenipatia surprise.
It is the reality, the sad reality that, you know, she's even shedding tears. Are you able to continue with your story?
Yeah.
Okay.
So venye nilienda, nilikuwa nimeshafanywa screening before. Nikaambiwa niko na cells na wakaniambia wameniweka dawa. Hiyo story ya niko sawa.
Endelea tu.
Nikaambiwa niko sawa, so daktari akuniambia nafaa nirudi after 6 weeks niangaliwe tena. So venye nilienda Bagavi, daktari aliniambia mbona umekaa hivyo, mbona hukurudi after 6 weeks? Nikamwambia mimi sijui. So ndio daktari akaniambia ninaona tufanye hizi test juu naona ni kama uko na cancer. So wakanifanyia pap smear, wakaniambia nipeleke Dr. Plaza. After 1 week nikaendea results, nikarudisha. So wakaniambia ati kesi yangu lazima niende clinic 18. So after 18 kuna daktari akaniambia gyno. Kuna gyno akaniambia niende nifanye MRI. Kwangu kufanya MRI imekuwa ni challenge kwangu juu sikukuwa na hiyo pesa. Nikienda kila mahali wananiambia 37,000, 31. So nikachoose penye ilikuwa ni cheaper, nikaenda kwa 31. So ili take time kabla nirudishe hiyo result ya MRI. So kurudisha result ya MRI ndo wakaniambia kulikuwa na hii time holiday ilitokea from nowhere. So kurudi tena daktari akaniambia niende nifanye CT scan. Bado CT scan ilikuwa ni challenge kwangu juu kurudi nilienda Germany wakaniambia wachukuisha. So nikachanganyikiwa. So ikabidi niende KU penye nilifanyia MRI nikafanya CT scan.
Okay, asante sana Jacqueline kwa story yako, and thank you for being courageous to share the story. One thing that you can note from both stories, it's about the cost of treating cancer. And before that, let me take you to our studio with Liz Mutuku, who will take us to Mombasa. Liz Mutuku, over to you.
Naam, asante sana Sheilar Chelangat na timu yote kutoka upande huo wa Chandaria katika Chuo Kikuu cha Nairobi, ambapo mjadala huu wa kikao unanoga kuhusiana na swala la saratani, siku ambayo tunaendelea kusherehekea na kujijuza mengi kuhusiana na ugonjwa wa saratani, lakini mzigo wake siku zote unasalia changamoto, sio kwa umoja bali kwa wengi katika taifa hili la Kenya. Nitakuwa nikizungumza na Daktari Pukose ambaye ni mwenyekiti wa kamati ya afya bungeni kuhusiana na mzigo huu, matibabu yenyewe na baadhi ya yale ambayo wameweka kama bunge kuhakikisha kuwa Wakenya wanafaidika na kusaidika. Lakini kwa sasa tunawapisha wahisani wetu.
Are you ready to elevate your business game?
As long as you're earning something, there's always that opportunity to save. And you start with where you are.
Kama wewe ni mfanyabiashara, huwezi kaa bure, unajipanga taratibu vile inavyofaa.
Join us each week as we dive into the stories of the world's most driven entrepreneurs.
When you pay attention to detail, you get luxury items.
The Grind, where business meets brilliance. Tune in every Monday at 7:30 p.m. because your business deserves the best.
Hey there friends, welcome to Kids on the Block, where fun and imagination come alive. We dive into magical world filled with exciting adventures and awesome friends.
What position were you in? I was number 2.
What position were you?
Number 1.
He decided to cross the bridge by his house and look for food on the other side.
We're going to do half cup of chocolate chips, and the other one, we're going to do half cup of the blueberries.
So, grab your imagination hats and get ready to explore with us. Join us every Saturday at 9 a.m. for new friends, amazing stories, and tons of laughter.
Join us as we explore the journeys of those who defy the odds and break barriers. We dive deep into the stories of triumph.
Sometimes when parenting a child with a special need or whatever disability, family life becomes a bit complicated and you may end up raising the child on your own.
Here, we inspire.
I have a farm which one we showcase with other dyslexic youths and autism how to farm.
Motivate.
It's never easy, but what we do, the best thing is to work with another parent who has an elder child than yours.
And break through the barriers one story at a time. Push your boundaries beyond the limit. Saturdays at 8 p.m.
Karibu katika kikao mara tena ukiwa nami Elizabeth Mutuku, lakini katika ukumbi ule wa Chandaria katika chuo kikuu cha UON unazungumza moja kwa moja na wale ambao ni wanahabari wetu Linda Alela, Joash, Onsare na Sheilar Chelangat wakiwa na wataalam katika swala hili la kupambana na janga la saratani, na siku ambayo Kenya na ulimwengu kwa pamoja tunaadhimisha siku ya saratani. Lakini nilivyokuahidi nikikwenda mapumzikoni, tutakuwa tukiungana moja kwa moja kutoka kaunti ya Mombasa na mwenyekiti wa kamati ya afya pale bungeni, wakati ambapo Wakenya wengi wana maswali kuhusiana na mzigo wenyewe wa kutibu saratani. Tumewasikiza wawili watatu kuhusiana na yale wamepitia, hata wengine kukosa matibabu. Kumbuka lilikuwepo hakikisho kwamba bima ya afya SHA itakuwepo pamoja na kushughulikia, lakini kwa wale ambao wameafikia swala la kutafuta matibabu kupitia bima hii, kumekuwepo na maswali. Pia bunge imepiga hatua gani? Karibu sana daktari, na asante kupata nafasi kuzungumza nasi jioni ya leo.
Shukran, asante.
Nitaanza kwa kuuliza hili. Bunge limepiga hatua gani kusaidia kupambana na janga la saratani? Manake Wakenya wengi wanafariki dunia kutokana na ugonjwa huu.
Asante Elizabeth. Nafikiri nitaijibu kwa lugha ya Kiingereza kwa sababu saa ingine lugha ya Kiswahili inakuwa ngumu kidogo.
Okay.
In terms of parliamentary role,
yes,
you know Parliament has 4 roles: 1, legislation; 2, representation; 3, oversight; and 4, budgetary allocations.
Yeah.
In terms of legislation, we've done the law to create the National Cancer Institute, which is one of the sagas under the Ministry of Health, Medical Services, State Department for Medical Services. And the National Cancer Institute has a lot of, it has mandate in terms of management of, in terms of research, training, and in terms of cancer treatment. Apart from that, we've also done other amendment laws in terms of the Cancer Control Amendment Act, which the Parliament has passed. Recently, we had an amendment by the member for Imendi North on cancer control management, control and prevention. One of the roles is allocation of resources, and in terms of allocation of resources, we oversee the budgetary allocation to the National Cancer Institute. 2, we also have regional cancer centers, which have been set up through the national government. These regional cancer centers are in we have one in Garissa, we have one in Mombasa, we have one in Nakuru, and recently we have one which is coming up in Kisii. All these regional cancer institutes have, they have radiotherapy machines, and they also have capacity building in terms of management of cancer within those areas. As you realize, if somebody has to travel all the way from northern Kenya to come to Nairobi for cancer management, it takes ages, and that is informed the decision to form a regional cancer center at Garissa. In addition to that, are you getting me?
Yes, I'm getting you, Mheshimiwa.
Okay, in addition to that, we've also supported our national referral facilities, that is Moi Teaching and Referral, Kenyatta National Hospital, and KU Teaching and Referral Hospital, in terms of setting up the Department of Cancer with the radiotherapy machines, with other state-of-the-art equipment which enables them to manage cancer within those areas, and also supporting them in terms of budgetary allocation for the management of cancer.
Mheshimiwa, as far as national government is concerned, how far are we when it comes to equipping the health facilities to dealing with early stages of cancer?
You know, the early stages of cancer is not just a responsibility for healthcare workers. One is one of the things which you realize from the cases which are diagnosed. Most of them are diagnosed when it is late, and this has something to do with culture and also misdiagnosis, because when you find that somebody is going to the hospital, like now the lady who said she went to Mbakadi and she was being treated for UTI and pelvic inflammatory disease, you realize that, and then she's gone through a lot of problems to be able to come up with the diagnosis, where you find that she's being told to do an MRI after pap smear has been done. The doctor is, after even doing an MRI, the doctor is still asking her for a CT scan. You know, this to me, this sums up to what we could say misdiagnosis. And even in a way, you would say, first, this doctor needed to even has done the staging for this cancer. And by sending her to go through all those other processes, I think it is it is a way that this is where we need to have a proper way of management of cancer within our country.
And one will want
One of the things that we've done as a parliament is to give resources to our referral facilities. And these referral facilities are capable of even doing the simple pap smears, staging those cancers, and promptly beginning even the management in terms of treatment. But you'll find that it is very sad when a client has to travel all the way from one corner of the country, maybe to come to Nairobi or visit a referral facility so that proper diagnosis can be done. I think what we need to do is to encourage our county facilities to be able to have equipment that can be able to make the correct diagnosis early enough to enable early detection, early diagnosis of cancer, and initiate proper management, or even proper referral to the various health facilities where proper management can be done.
Mheshimiwa, you've spoken of county facilities being at least enabled as far as it comes to dealing with cancer. But one is left wondering, with the allocation which is given to counties, are we really fighting with this giant disease in the country?
You know, through the division of revenue bill, you have an allocation for the counties and you have an allocation for the national government. Then the national government now will start to budget for its national resources to the various ministries. Counties will also be, the Senate will also distribute that money to the various counties. Then each county will now be able to allocate its resources to its various departments. The biggest role for county governments is health. The second biggest role for county government is in terms of road infrastructure and water. If counties are able to allocate their resources, and we are able to evaluate to see how much has gone to the various counties in terms of, because right now when you look at what goes to the counties, you are not able to clearly give a general even overview of how much resources is allocated to health. in line with even the Abuja Declaration, how much the country, the national government puts, how much the counties are putting. And therefore, I think one of the things that we need to do is, now that we have the national government having put in place universal health care, and under this universal health care, you have funding to primary health care, you have funding under the primary health care to level 2, level 3, and even level 4 outpatient. So this should be able to enable counties to be able to allocate, to be able to equip their facilities with both medication, equipment, and the necessary human resource. Because counties will now be able to claim from the Social Health Authority money for provision of healthcare services at level 2, that's at the dispensary, money for provision of health services at health center level, and this money can still be plowed back, because we've passed as Parliament the Facility Improvement Fund that makes sure that every money that is generated from that facility will now be able to be plowed back to the health facility. Unlike the past, or where it is not being operationalized, where the money that is generated from the health facility does not go back to the health facility. In addition to that money which is now coming from the FIF, you have the resource envelope, which is from the Division of Revenue Bill to the county, so that the county can now be able to allocate that resources to the various. The law also allows cooperation and consultation between the national government and the county government. So national government and the county government can work together to look at what are the options in terms of deficits, in terms of maybe human resource or even equipment, where counties are not well equipped. Can we be able to look at ways of how can we equip those health facilities to meet the services that is as per that level of facility, either as a dispensary or as a health center, to make sure that we are able to put the necessary equipments so that we can have to provide robust health care.
Mheshimiwa, you've spoken of having the right equipment in the counties. And then you remind me of the MES, that is Medical Equipment Scheme, which was supposedly to help the counties in dealing with such diseases. Do you think this was a scheme which, or rather the scheme was helpful as it was anticipated?
The managed equipment service was a good idea. I think the only problem was when it came to implementation, because under the managed equipment service scheme, 2 health facilities per county were equipped. But unfortunately, what happened is that in some of the facilities, because it was not properly implemented, you will find that you have an equipment that has been pushed to you, and you don't have the necessary human resource to utilize that facility. I think these are lessons that we've been able to learn from that mistake. That now, under new arrangement, counties can be able to sit down, come up with an audit of the health facilities they have. What do those facilities have? What do they require? Do we have the necessary human resource to be able to deliver that service? And how do we procure those equipment to make sure that our people are able to get the necessary service and not incur costs that are detrimental or that are not beneficial to the community? So I think the managed equipment service was a good idea, but implementation was a problem, and we've learned our lessons. And I think moving forward as a country, because you cannot do with those facilities when the facility is not well equipped, when the facility has no correct human resource, and when facility has no commodities, that's the health products and technology. So we must be able to make sure that we put our healthcare in the correct position so that mwananchi does not, you'll ask yourself, why do people prefer at times going to a private facility when they have money? But when you look at statistics, because one of these NGOs made a presentation the other day to the health committee, 65% of Kenyans visit public health facilities. That is their first call of center for service. And therefore, it calls upon us as a government to make sure that if 65% of our population, the first call of center for the healthcare provision is a public health facility, why don't we make sure that this public health facility is at a level that can be able to meet the requirements to provide the diagnosis and the treatment for those 65% who will be able to call as a first call of service within our public health facilities.
All right. Do you think really we've invested much when it comes to research and sensitization of public or in terms cancer, matters cancer?
Thank you again. When you heard from the representative from KEMRI, they've had the Nairobi registry for close to 20 years. But when you look at the Nairobi registry, it is USAID funded. It's not locally funded. It's foreign-based funding. So one of the biggest challenges has been in terms of funding to our healthcare, where especially when it comes to research and research in terms of for cancer, most of it has been foreign funded. But of late, as a committee of health, we've tried to provide resources to the National Cancer Institute. We've also encouraged our institutions that are engaged in research, like KEMRI. We've, for the last, I think, since 2015, we've been funding KEMRI for research. And what we've asked them to do is to look at research that addresses local problems. Initially, we've had KEMRI looking at issues about Mira. They've done a research on Mira. They've done a research on pyrethrum. And we have, and KEMRI, I think we've also given them some funds, and we are hoping that with those funds, they are also looking at, I think, herbal medicine. But I think it is high time that we do research that is targeting our local challenges, and the cancer being one of the biggest threats to our health care. I think we'll be able to, as a committee, to support research, especially that looks into cancer. I think the other day we had a member from Meru presenting issues about cancer being rampant within that area, and also Taita Tafeta. I think these are issues that have been raised by members from those various areas, and we would encourage our research, especially KEMRI and National Cancer Institute, to be able to look into those areas and see what is it that the committee, and I know both the health committee and the budget committee has been very supportive when it comes to cancer research and what we can be able to do. I think even when Kenyatta presented and Moi Teaching and Referral and Kenyatta University, where they bought the other day CyberKnife, which is fully funded by the GOK, and other cancer radiotherapy machines, which have been fully funded by the national government. I think we've been very supportive, and we'll keep on supporting them.
We're really looking forward into this budget to see what you will do as the chair, the health committee. But I will not let you go if I will not be asking about the SHA, because majority of Kenyans were so hopeful that SHA is going to be of great help when it comes to dealing with cancer, but it's proving otherwise, Mheshimiwa.
I think it's the opposite. You know, SHA it's not been long since it was launched in September, in October. And to say that it's not doing, you know, I tend to think we are rushing into conclusions very fast.
We are not
SHA has a component of chronic, critical, and emergency illness. And this is that's a fund which is supported fully by the national government through Exchequer. In the last budget, we allocated we've allocated to close to, I think, 2 billion. Then the primary health care we put 4 billion. This is a start, and as it continues, we'll be able to look at how much subsequently we can be able to allocate. You know, this is not money that will be consumed within a day. This is money that is going to be utilized within a period of a financial year. We started the financial year, we started the fund in October. The financial year is ending in June. We will have supplementary budget in this February. Meaning between October and February, we'll be able to look at how much of that has been utilized in addressing chronic illnesses, which cancer falls among them. Critical, when somebody maybe has now gone to stage 4 or stage 3 and is in a situation that maybe requires intensive management. And therefore, I think we need to look at the context of that amount that has been allocated in line with the budget cycle, so that we don't make conclusions that SHA is already failing when we are trying now to make sure that everybody is being brought into SHA, people are registering, and we see how much of that is being consumed in terms of resources that the national government has allocated.
All right. Thank you so much, Mheshimiwa, because I know very well we are supposed to go to other matters, but Victor Muyakane will be continuing with the same line of questioning when it comes to cancer and the burden of cancer in the country. Lakini kwa sasa na shukuru kwamba umenipa muda wangu na muda wetu hapa ndani ya studio hizi za TV47 kuzungumzia hili na kupata pia nafasi kuzungumza nasi. Kwa sasa tunachukua mapumziko kidogo na baadaye tutakuwa tukirejea katika ukumbi ule wa Chandaria kuweza kuangazia haya na mengine mengi zaidi. Kumbuka pale pana wale ambao ni waadhiriwa, kuna wale ambao ni wataalam na pia wanahabari wetu ambao ni mahiri zaidi kuhusiana na swala hili la kupambana na saratani. Na endapo pia wewe upo nyumbani na una maswali, ni kwa 22047 na sisi tutakuwa tukipitia moja kwa moja ili kuweza kuwasiliana nawe. Lakini kwa sasa ukae nasi wakati ambapo tunapumzika dakika 2 kisha tuingie kwa habari.
Are you ready to elevate your business game?
As long as you're earning something, there's always that opportunity to save. And you start with where you are.
Kama wewe ni mfanyabiashara, huwezi kaa bure, unajipanga taratibu vile inavyofaa.
Join us each week as we dive into the stories of the world's most driven entrepreneurs.
When you pay attention to detail, you get luxury items.
The Grind, where business meets brilliance. Tune in every Monday at 7:30 p.m. because your business deserves the best.
Hey there, friends. Welcome to Kids on the Block, where fun and imagination come alive. We dive into magical world filled with exciting adventures and awesome friends.
What position were you in? I was number 2.
What position were you?
Number 1.
He decided to cross the bridge by his house and look for food on the other side.
We're going to do half cup of chocolate chips, and the other one, we're going to do half cup of the blueberries.
So, grab your imagination hats and get ready to explore with us. Join us every Saturday at 9 a.m. for new friends, amazing stories, and tons of laughter.
Join us as we explore the journeys of those who defy the odds and break barriers. We dive deep into the stories of triumph.
Sometimes when parenting a child with a special need or whatever disability, family life becomes a bit complicated and you may end up raising the child on your own.
Here, we inspire.
I have a farm which one we showcase with other dyslexic youths and autism how to farm.
Motivate.
It's never easy, but what we do, the best thing is to work with another parent who has an elder child than yours.
And break through the barriers one story at a time. Push your boundaries beyond the limit. Saturdays at 8 p.m.
All right, the discussion will continue shortly, but as well, we're here to let you know what is happening around you and beyond. My name is Linda Alela. Once again, I'll be assisted by my sign language interpreter on the other side. That is Catherine Simeloi. Lots lined up for you, but first, the highlights. Tonight, former Deputy President Rigathi Gachagua alleges that he was promised 2 billion Kenya shillings to step down from his position in order to vie in future.
Because alikuwa ameniambia wewe jiuzuru nikupatie bilioni 2 uende nyumbani, uende upumzike.
And President William Ruto reassures the nation that the 5 Mandera chiefs who were recently abducted will be safely returned.
Hawa machief lazima warudi nyumbani, na hawa wakora na wagaidi na wahuni tutabambana na wao.
This as he says that his government has committed to continuing the fight against criminal gangs and terror groups. Also tonight, the Office of the Ombudsman has stated that it will hold the judiciary accountable for the delays in legal proceedings, emphasizing the need for timely resolutions in cases.
We are not giving ultimatums. We are requesting and we give them timelines based on our Access to Information Act. We are simply following the law.
All right, and straight to the news of the day, where President William Ruto has strongly condemned the abduction of 5 chief officers that played out on Monday morning in Mandera's Wargadud area. He has assured the nation that his administration is doing what that they can do and everything possible to ensure that there is safe return of the abducted chiefs, as well as Samira Mohammed then details the president has vowed to intensify efforts against criminal gangs as well as terror groups, adding that the government is committed and will not tolerate such acts of lawlessness. Let's take a look at that.
Following the abduction of 5 chief officers on Monday morning in Mandera County by people believed to be Al-Shabaab militants. Today, President William Ruto, while on his northeastern tour, has strongly condemned the incident.
Tunapigana na wahuni na wakora na wahalifu pamoja na magaidi. Na kwa sababu hawa magaidi tumewalemea jana kwa sababu ya kutaka kulete hali ya hofu sehemu hii, ati walienda wakashika machifu wetu.
Vowing to sustain the fight against criminal gangs and terror groups, the head of state has now assured Kenyans that the 5 abducted chiefs will be brought back home safely.
I want to promise the people of Mandera, hawa machief lazima warudi nyumbani, na hawa wakora na wagaidi na wahuni tutabambana na wao. Nimekuja na Deputy Inspector General wa polisi yuko hapa, Bwana Masengeli.
Following the incident, which has raised tension in Mandera County, President Ruto stated that the government has significantly downgraded the ability of the Al-Shabaab to unleash violence on the people of Kenya, and the government will not stop at anything to ensure northern Kenya is safe like any other part of the country. The head of state vowed to protect the integrity of the nation and that the nation will not cede an inch of any part of the country to criminals who want to unleash mayhem.
Na Masengeli nishamueleza ya kwamba juu chini, kulia kushoto, mbele na nyuma, east or west, mpaka mambo haya yatatuliwe, kwa sababu we have significantly downgraded the ability of the Al-Shabaab to unleash violence to the people of northern Kenya, and we will not stop at anything until we make sure northern Kenya is safe like any other part of the Republic of Kenya.
The head of state further addressed the motive behind the abduction, suggesting that it was an attempt to intimidate him to deter his visit to the northern region.
Walikuwa wanafikiria ya kwamba wakifanya hiyo maneno walifanya jana, ati ndio nisikuje hapa. Mimi sio ati nimekuja Mandera, nimekuja na Mandera na mimi nalala Mandera. Na ikizidi naweza kulala tena, kwa sababu hapa ni Kenya.
The 5 chiefs were abducted by people believed to be Al-Shabaab militants in Wargadud en route to Elwak. The 5 are Mohammed Adawa, Mohammed Hassan Kulmiang, Abdi Hassan Surey, Mohammed Nur Hachi and Ibrahim Gabo.
Suspected Al-Shabaab militants mounted an ambush on unsuspecting road users at that particular space, and they got a vehicle that was carrying some chiefs, 5 of them, members of the National Government Administration, who were on their way to Elwak here for a meeting.
President William Ruto, who commenced his northeastern tour today, is expected to proceed with his tour to Wajir on Wednesday. Samira Mohammed for TV47, Nairobi.
In the same breath, the president is expected tomorrow to go ahead and revoke mandatory vetting for identity cards for communities in the northern region of Kenya before they are issued with the vital documents. And speaking in Mandera County, where he kicked off his week-long tour that is to the northern region, President William Ruto, of course, said that the policy initiated during the Shifter War, that is in the 1960s, is discriminatory to the people of the region, as Apollo Kamau tells us.
President William Ruto will make history on Wednesday when he revokes a 60-year-old government policy that imposed a mandatory vetting for Northern Kenya residents before they can be issued with IDs.
Children of Northern Kenya are not treated differently from the children of other parts of Kenya. Na ndio kesho mimi niko na ceremony kubwa ya kuondoa once and for all ile maneno ya vetting ambayo ilikuwa inagandamiza watu wa Northern Kenya.
Miaka 60 tulikuwa tunaambiwa ukitaka kupata ID na passport mpaka wewe upitie vetting. Serikali ya hayati Kenyatta, serikali ya mzee Moi, serikali ya mheshimiwa Kibaki, serikali ya mheshimiwa Uhuru hawakufanya yale uliyofanya.
The president, who kicked off his northeastern development tour in Mandera, said he will revoke the policy, terming it as discriminative to the residents of the region.
It is my responsibility to make sure that Kenya is united and Kenya is one, and every Kenyan is treated equally with the rest of the Kenyan communities and the Kenyan citizens of the Republic of Kenya.
And we stand for one Kenya. We stand for the unity of the people of Kenya and equal development of all parts of Kenya. Mandera, tumesikizana.
Viti za chini watu wanaweza wania, kiti ya president debe ni moja, na hiyo ni ahadi tunatoa mbele ya jamii yetu ya Mandera. Mandera ama gani?
Former Deputy President Rigathi Gachagua was in the president's crosshairs after President Ruto accused him of dividing Kenyans through his payslip narrative. Gachagua maintains Kenyans are suffering through overtaxation as reflected by their payslips.
Ati mpango yao yote ni vile watagawanya wa Kenya. Kama hawasemi mambo ya ukabila, wanasema mambo ya sijui dini. Kama hawasemi mambo ya dini, wanasema sijui nani wa kutoka mulima, nani wa kutoka bonde, nani wa kutoka bara, nani wa kutoka ziwa, nani wa kutoka wapi. Kama hawafanyi hiyo, wanasema nani yako na kazi, nani hana kazi. Nani yako na payslip, nani hana payslip.
President Ruto, who inspected several projects, among them the Mandera Water and Supply Sanitation Project, urged the region to vaccinate their livestock and pledged the expansion of the 750-kilometer Isiolo-Mandera Road, which is jointly funded by the Government of Kenya, the World Bank, and the Africa Development Bank at a cost of 100 billion shillings. Apul Kamau, TV47.
All right, and away from the Northeast region, we come back here, where former Deputy President Rigathi Gachagua has dropped yet another bombshell regarding his removal from office, claiming that President William Ruto offered him 2 billion Kenyan shillings, that is to step down and exit the Kenya Kwanza government. And speaking during a Tuesday morning interview with Western radio stations, that is Western Kenya radio stations, the former Madeira Member of Parliament as well alleged that President promised him a salary, security detail and a chance to run for office, that is in future. And as Micah Gungu now reports, the claims add to the twist of the ongoing political tensions that play out between the two leaders, and of course both of whom are vying or are of major influence, that is in the western region, as they seek to lure or to woo them.
Former Deputy President Rigathi Gachagua has once again revealed the inside details happened before his ouster from office last year, following his broken relationship with President William Ruto.
Hakuna mtu anaweza unda serikali peke yake.
Speaking during an interview with Western radio stations Tuesday morning, the former Madeira Member of Parliament said in an effort to calm the situation and provide him a chance to vie for a political seat in future, President Ruto offered him 2 billion shillings, which he turned down.
Na mimi ningesikiza vile rais alikuwa ananiambia nijiuzuru, because alikuwa ameniambia wewe jiuzuru nikupatie bilioni 2 uende nyumbani, uende upumzike, fanya mambo yako, kuwe na security, kuwe na mshahara na unaweza simama siku nyingine. Sasa nikajiuliza, yule anakupangia mabaya anaweza kukupatia suluhisho ya vile utaishi?
The former DP described himself as a selfless leader who had no desire in seeking for any political office. He also stated that even members of parliament who supported him had encouraged him to step down so that he could have a chance to run for office in the future.
Mimi sijipendi. Hata wabunge ya kwangu wengi sana wale wananiunga mkono walikuja kuniona kuniambia, wewe jiuzuru ndio ukue upate nafasi ya kusimama. Nikasema hiyo ni kujipenda, sio lazima mimi nisimame, sio lazima niongoze. Mimi lazima nijitolee, nitetee wa Kenya na ukweli ujulikane.
Despite supporting Gen Z's demand for a better Kenya free from all types of injustice, Gachagua refuted claims that he was the brainchild behind the wave of anti-government demonstrations that took place last year.
Si mimi si kuongoza Gen Z na si kutoa pesa, lakini hao ni watoto wazuri. Kama wageni kubali niwe mkubwa wao, ningefurahi sana. Ningekuwa na umaarufu kubwa sana. Kwa sababu Gen Z ndio wataamua hii Kenya nani ataongoza. Ile force iko na Gen Z ni kali sana.
In his efforts to woo Western region, the former DP pleaded with the Mulembe Nation to unite and form a strong movement, together with his Mount Kenya backyard believed to be the richest region with presidential votes.
Sio lazima ikuwe ni mimi, sio lazima Kalonzo aseme ni yeye, sio lazima Amano aseme ni yeye, sio lazima Matiang'i aseme ni yeye. Tutaketi chini kama tu. Wacha kila mtu aunganishe kwake. Tukishaunganisha huko mbele 2026 huko December, tuketi tuseme hapa kwa mesa tumeweka kula milioni 15.
Gachagua has since united with Western region leaders including DAP-K party leader Eugene Wamalwa, Trans Nzoia Governor George Natembeya and Cleophas Malala in his efforts to destabilize President William Ruto's foundation. Mike Kagwango, TV47, Nairobi.
All right, and if you thought that these squabbles lie just in the side of politics, then you are wrong, because guess what? The Commission of Administrative Justice, that is CAJ, has launched a scathing attack that is towards the judiciary, accusing it of inefficiency as well as failing to act on complaints about misconduct. And the Commission has questioned just how or why no decisive action has been taken against magistrates as well as judges of unethical behavior, and equally including bribery and equally professional negligence, as Paul Kirubi tells us.
Thank you very much, the Honourable Chief Justice, for...
Just days after Chief Justice Martha Koome expressed concerns over the withdrawal of her security personnel, the Commission on Administrative Justice CAJ has launched a fresh challenge. The Commission has given the Chief Justice 21 days to submit a compliance report detailing the status of complaints related to the judiciary to the Office of the Ombudsman. CAJ has raised serious concerns about the conduct of certain judiciary officers and their ability to carry out their duties without facing repercussions. In a detailed analysis released on Tuesday, several serious allegations were raised, including a specific case where a magistrate was accused of fraudulently accessing funds from the judiciary's deposit account. The removal process for this magistrate was initiated in 2019, but up to now the matter remains unresolved, and 6 years down the line, the magistrate is still in office. Another magistrate was accused of alcoholism, soliciting bribes, and delaying court proceedings. This case is also still unresolved, raising concerns about efficiency in handling such cases.
449 cases. In terms of inefficiency, we have 91 cases. Manifest injustice 52, unresponsive conduct 49, unfair treatment 32, unofficial conduct 6, inaction and ineptitude follows in that order.
One magistrate faced accusations of delaying 30 judgments, while another was accused of delaying 250. The magistrate responsible for the 30 judgments was dismissed, while the one accused of delaying 250 judgments was acquitted. The disparity raising concerns about the fairness and consistency in how similar complaints are handled.
He issued an advisory to the judiciary asking them to publish this information. The response was very flattering. They sent somebody to write to us that one, they're independent, and two, they said we addressed them through social media, which is not the case, because the letter was delivered to the chairperson of the JC then.
Another set of allegations has been directed at a judge who is accused of having a backlog of 32 delayed judgments and issuing verbal rulings without written judgments, making them inaccessible to litigants and advocates. In a separate case, the judge upheld a lack of jurisdiction in a commercial matter, but still awarded a counterclaim of 59 million shillings in the same ruling, resulting in a loss of over 400 million to the state. To date, out of the 700 complaints lodged, only 302 have been resolved, with 398 still pending. Paul Kirobi, TV47, Nairobi.
18 miners have been successfully rescued as efforts are underway to save 2 others that are still trapped under the rubble that is following a gold mine collapse in Museno area, Kakamega County. The National Vice Chairperson of the Gold Miners, that is Association, Patrick Ligami, has confirmed that no fatalities have been reported so far. That is from the tragic incident which occurred last night. And now Violet Auma gives us the latest updates as to this occurrence.
Anxiety and fear have gripped Machilifu village, Museno in Shinyalu constituency following a tragic mining accident that buried 20 miners alive. This evening, the bodies of 2 miners have been retrieved, while 18 others who were rescued last night and earlier today were rushed to Kakamega Referral Hospital for treatment.
Venye tulikaa asubuhi ikafika, watu wameweza kuondolewa hapo. Watu wameondolewa hapo watu 10, alafu mimi nikangoja mzee nione mzee, si kumuona. So nimehuzunika sana, ni kwamba mzee ameweza kuondoka. So nimehurumika sana, muniombee.
Wale ambao wametolewa na wetu baada hatujafahamu kumuona, kwa hivyo hatujui nini kinaendelea kule ndani.
The Deputy Chairperson of the National Miners Association, Patrick Ligami, confirmed that rescue teams had deployed machinery and oxygen pumps inside the mine in a desperate attempt to save the 2, but it was too late. This is not the first time such a tragedy has struck Kakamega's mining sites. In 2019, a similar disaster at the Rosterman mine claimed the lives of 10 miners, while in 2018, another collapse in Ikolomani constituency led to 6 fatalities.
Serikali isaidia watoto vifaa kwa sababu hii kuchimba gold kumeokoa wananchi, ile wizi ilikuwa inaendelea kuwa na kukatakata watu.
Local leaders are now calling on both county and national governments to provide training and better equipment for artisanal miners to prevent such recurring accidents.
Inafaa wakuje wapeane safety na PPEs. Hiyo itasaidia vijana wetu katika kuweza kujiokoa kwa sehemu zingine. Alafu wapewe training.
If the county government cannot bring the immediate rescue to this our people, that's very wrong.
We wish that the national government was functioning. Hatuoni support ya national government sahi. Hatuoni support ya county government sahi. Kitu yenye tunaona tu ni kupitisha hapa ma-ambulance. Ma-ambulance is after the fact. What we need here is the fire brigade. Iwe imeangusha hiyo mashini yao mpaka chini. It has the capacity to go far deep. It pulled people out.
Meanwhile, 8 of the 18 rescued miners have since been discharged from the hospital. Violet Auma, TV47.
All right, and of course some good news coming all the way from the DRC, that is Democratic Republic of Congo, after a week of intense fighting that is between M23 rebels and government forces that is in eastern Congo, resulting in over 900 deaths so far. The rebel group has announced a ceasefire and set to take effect, that is on Wednesday, tomorrow. This unexpected move comes as regional leaders prepare for a high-level talk that is aimed at resolving the crisis, as George Maringa tells us the latest development.
M23 declared immediate ceasefire effective Tuesday to pave the way for humanitarian aid. The rebel group also said that it has no intention of capturing Bukavu. Both Congolese President Felix Tshisekedi and Rwandan President Paul Kagame are set to meet this Saturday for a summit chaired by President William Ruto, aimed at de-escalating the crisis. The talks, which will include leaders from East Africa and Southern Africa, are seen as crucial in preventing further regional conflict. This summit will be preceded by a ministerial meeting on Friday where key foreign ministers and diplomats will lay the groundwork for the heads of state. On Saturday, the leaders will take to the table for the summit itself, where they will discuss potential peacekeeping measures, diplomatic solutions and strategies to de-escalate the situation. While much remains uncertain, there's hope that this summit could serve as a turning point in the region's efforts to bring peace to the DRC. The commitment shown by these leaders is crucial as they aim to send a strong message of solidarity, not only for the DRC, but for the entire African continent. The ceasefire announcement comes just days after M23 forces claimed control of the city of Goma, a major urban center of over 1 million people. Though fighting has subsided in the city, clashes have now reportedly spread to the neighboring province of South Kivu. With hundreds of thousands displaced, many fear the ceasefire may not hold. The M23 says it has no plans to advance to the city of Bukavu, but these claims have raised doubts as ceasefire agreements have repeatedly failed in the past. As the situation evolves, the question remains, will this ceasefire hold? George Maringa, TV47, Nairobi.
Thank you, George, for the updates on what's playing out on the other side. But equally, we want to look at the health situation in the country, that is as to the Taifa Care that has been rolled out or was rolled out by the government. Remember, the discussion today is largely about cancer and equally the health concerns in the country. And so the Health Cabinet Secretary, that is Deborah Barasa, has reaffirmed the government's commitment to rolling out Taifa Care across the country, noting that over 500,000 of Kenyans have already benefited from this program. And speaking in Nanyuki while launching our tobacco and substance abuse campaign, Barasa acknowledged existing challenges, including systemic failures and delays, particularly for nomadic communities that are facing difficulties with ID registration. And she has assured that these concerns will then be addressed to improve accessibility and efficiency.
We had very few people having had NHIF. Now we have more than 18 million Kenyans, you know, almost three times the number that was in NHIF. And again, we are looking to, you know, have more Kenyans on board. The whole, almost 100%, that is Taifa Care on board. So there are people in Kenya who could not access services. That is where we are coming from, you know. So the problems of system interruption, yes, and we are addressing them, you know, expeditiously. We are happy that we now have the server that came in on Friday, and now they are working to the technical issues to ensure that it's working efficiently. And what we can say, yes, during this time, bear with us, but ultimately, if each and every Kenyan can be able to access services, whether you are rich or poor, I believe that this would be, you know, a game changer for all of us as Kenyans. Because when you look at other systems, they have everyone accessing care. That is the bare minimum, you know, that is the threshold. Then after that, now we can review the concerns of waiting time, system challenges. But for now, accessibility, affordability, and quality is really critical so that all of us can access care.
And time for business news, where in a move aimed at supporting small as well as medium, that is the SMEs in the country, or the business persons, the Kenya National Chamber of Commerce and Industry, KN, partnership deal with Ishida, a leading Japanese packaging company, and the collaboration seeks to enhance business performance through innovation, capacity building, as well as market engagement. According to KNCCI chairperson, that is James Mwaura, the partnership will not only promote Ishida's products and services right here in the country, but also drive joint initiatives designed to support SMEs. And Africa Ishida Limited General Manager, that is Melika Seiderera, highlighted that the collaboration then will enable knowledge sharing and capacity building to address key challenges and unlock new business opportunities.
MOU, which we are signing up with a company all the way from Japan called Ishida. They'll tell us exactly what they do. From KNCCI, our biggest job is to enhance business from SME all the way to corporate. So today they have come, we're sending up an MOU. We'll be doing their advocacy in the country. They're just doing their setup in this region. So we'll introduce them to all our partners in Kenya and around Kenya. So today is a big day for them. We'll show them the business ecosystem which we have in the country.
We understand the landscape and the economic climate at the moment. So our plan is to be flexible in our support of the local communities. Those that can afford to buy machinery have always been traditionally very slim, but it is the 80 to 90% of businesses that need access to the machines. Our plan is to grow employment through our business and then to diversify our products. So we will start looking at who can build ancillary equipment, perhaps who is in industry that manufactures or engineers. That is one way that we can help build the economy, is to get suppliers to us locally.
Sports News brought to you by Maybets.
Bumper tells you it is time for sports, where Kenya's love for football is undeniable. But some fans take their passion way too far. And of course, the National Super League match on a Sunday evening between Nairobi United and Migori Youth at the M-Pesa Foundation Academy was marred by chaos when a fan, or a furious Migori Youth fan, lost their control after his team conceded a second goal. And in a fit of rage, the towering fan charged at the referee, overpowering security in his attempt to protest the goal. However, in an unfortunate twist, his wild kick intended for the referee ended up striking a fully uniformed policewoman instead. Well, despite the provocation, the officer displayed remarkable restraint and, of course, choosing to slap the unruly fan with her hat rather than resorting to more drastic measures. A true display of discipline, unlike the fan, whose actions only brought shame, that is, to the beautiful game. Well, rather unfortunate, and like politics, we're always told that even the game, please do not keep it right into your chest. And of course, the national women's basketball team, Kenya Lionesses, struggled to assert dominance in the FIBA AfroBasket qualifiers, suffering yet another defeat, this time to South Sudan. And despite going into halftime trailing by just 8 points, Kenya failed, that is, to contain South Sudan's fast break plays. And of course, in the second half, half, eventually losing 86-69 at the Hassan Mustafa Sports Hall in Egypt. And this defeat follows another setback, that is against regional rivals Uganda, who then comfortably secured a 78-56 victory over the Lionesses in their opening game. And however, the Kenyan side remains hopeful, that is to reviving their qualification campaign when they take to Burundi tomorrow, that is before facing host Egypt on Friday evening.
No. The defensive board, Washington on an island, top of the key! And Selina Okumu have not taken care of the ball the way they were supposed to, and now when it rains, it pours. Bang, bang.
All right, and the winners of the 21st edition of the Nairobi Standard Chartered Marathon have been awarded a total of 12.5 million shillings in cash prizes as a ceremony at a ceremony that was held in Nairobi today. The marathon, which attracted over 25,000 participants from more than 90 nationalities, saw Kurgat Kimeli and Gladys Chemutai emerge victorious in the 42-kilometer race, each bagging 2 million shillings. And now, of course, Wambua and Caroline Wanjira also received 300,000 shillings each. The event also raised a total of about 43 million Kenya shillings, which is donated to Future Makers initiatives and, of course, a program that empowers the youth and persons with disability through education, employability, as well as entrepreneurship.
Kubwa sana kwangu, maana ilinitoa mbali mahali niliko na hadi sasa bado ninasema asante, na nitakapo kupata chance ya kurudi tena, I'm ready to defend my title.
Let the athletes protect their sport, let them protect themselves, let them ensure that no prohibited substance that enters into their body, because we can confidently tell them that we will still continue implementing anti-doping program for the marathons. So it's for the athletes to ensure they protect themselves for anything that they are taking, for anything they are ingesting, for anything they are putting on their body, to ensure it doesn't contain any prohibited substance.
Sports news brought to you by Maybets.
Well, that's so much we had on news. I'll read two comments to remind you of the discussion tonight. That as to the cancer burden in the country, Beatrice Atieno says, I am happy to see Phoebe as one of the panelists. I have listened to her speak passionately about nutrition in other forums. Can she tell us something about cancer and nutrition, especially in the early stages? We also have nutritionists on board that as well will weigh in on that matter. And Patricia Karani says, Shah has made recommendations that oncology services like chemo reduce the limit from 600k to 300,000 Kenya shillings. What will someone do when they are told their limit is exhausted? Cancer drugs are very, very expensive. Yes, a polite reminder that the conversation on Kikao tonight will be culminating to us understanding whether indeed we have hope for the cancer burden right here in the country. And so allow us to pay some bills, and then we cross over to the other side where we still have the audience as well as the panelists and my colleagues Joash, Onsare, as well as Sheilar Chelangat, as we unpack the cancer burden and the situation in the country. After this break, we come back with that.
your business game.
As long as you're earning something, there's always that opportunity to save. And you start with where you are.
Kama wewe ni mfanyabiashara, huwezi kaa bure, unajipanga taratibu vile inavyofaa.
Join us each week as we dive into the stories of the world's most driven entrepreneurs.
When you pay attention to detail, you get luxury items.
The Grind, where business meets brilliance. Tune in every Monday at 7:30 p.m. because your business deserves the best.
Hey there, friends. Welcome to Kids on the Block, where fun and imagination come alive. We dive into magical world filled with exciting adventures and awesome friends.
What position were you in? I was number 2. What position were you? Number 1.
He decided to cross the bridge by his house and look for food on the other side.
We're going to do half cup of chocolate chips, and the other one, we're going to do half cup of the blueberries.
So, grab your imagination hats and get ready to explore with us. Join us every Saturday at 9 a.m. for new friends, amazing stories, and tons of laughter.
Join us as we explore the journeys of those who defy the odds and break barriers. We dive deep into the stories of triumph.
Sometimes when parenting a child with a special need or whatever disability, family life becomes a bit complicated and you may end up raising the child on your own.
Here, we inspire.
I have a farm which one we showcase with other dyslexic youths and autism, how to farm.
Motivate.
It's never easy, but what we do, the best thing is to work with another parent who has an elder child than yours.
And break through the barriers one story at a time. Push your boundaries beyond the limit. Saturdays at 8 p.m.
Jiunge nasi tunapoangazia safari za viongozi bora. Kutoka kwa ushindi mkubwa hadi masomo magumu.
Wakati wetu kwamba wasichana si wa kusoma, ni wa kuolewa, ng'ombe ipatikane, wazazi wakuwe watajiri.
Tunashughulikia yote.
I wish I were a better investor.
My parents taught me how to look for things for myself.
Tazama Mfahamu Kiongozi, ambapo kila kipindi kimejaa maarifa, mikakati na hadithi za kukuza azma yako.
For me to succeed.
Ja unusu.
Thank you for keeping it TV47. Indeed, this is the third edition of Kikao, where on this particular Kikao and Town Hall, we are talking the matters cancer. What is the cancer burden in Kenya? And just before the break, we have talked on research. We have talked so much about research, but what is the technical aspect of research? Do we have capacity as a country in matters research in cancer? And so with me in the audience is Dr. Francis. How are you? Could you please tell us now, what is the technical bit of research in cancer?
Thank you, Sheilar, for hosting us in this very beautiful auditorium at the University of Nairobi.
My name is Dr. Francis Wanyama. I'm an omics cancer researcher with the Department of Human Pathology, University of Nairobi, as well as Department of Clinical Chemistry at the Charité Medical University Berlin in Germany, where we are currently engaged in research that is biomarker oriented for gynecological cancers. So the problem we have here is that we have very good guidelines, very good templates coming from the government and the policies, but these are not accompanied with the resources. So this has led us, in a state where you only have frivolous kind of researches that lead to students' graduations, but they don't really impact the real management of the patient or change of the trajectory. And that's why you find that there was a survivor, a cancer warrior here who said, she was through and through many hospitals getting wrong diagnosis. And that goes to tell you, that we are also not investing in our human resource to build their capacity to be able to, to meet these challenges that are diagnostic in nature. A cancer like ovarian cancer, most of the time, the diagnosis gets it wrong. And you only come to diagnose it when it's very late in advanced stages. And actually, about 75% of the patients that are diagnosed with ovarian cancer are usually in stage 3 and stage 4. And the major reason is misdiagnosis and also lack of the specific tests. So as a country, we need to invest more in the diagnosis. But the problem you can see, it's even in the news today. We have invested much in politics. 2 billion can do quite a lot when it comes to research, researching on cancer. A serious research would take like 200 million. Yes. So you can imagine what 2 billion would do. But again, we have our priorities wrong.
Okay.
So we call upon leaders to really do much more and invest, follow these beautiful documents with the resources. Then we'll solve our problems.
All right. Thank you so much, Dr. Francis. And you bring up an important point, which is funding for this particular research. And even as we speak about research, allow me to engage another cancer warrior as you tell us now about the challenges. In 30 seconds, what are the other challenges as I let our panelists ponder on this question of funding?
Thank you so much. My name is Esther Wanjiko. I hail from Dandora. Nikiongelea mambo ya changamoto ambazo tunapitia sisi kama I'm a cancer survivor, stage 4 breast cancer survivor since 2022, and I'm still on treatment. Changamoto kubwa ni lack of knowledge. Hatujui kama tuko na cancer sisi wenye hatujapimwa. So tukiomba serikali venye tu wanafanya kama AIDS, wanaenda tu doorstep, wanakuja wanakuambia tuko na mpaka test kits tupime. So unapenda tu kidole chako unabua kama uko positive au uko negative. Serikali iko na uwezo wa kwenda mpaka kwa doorstep tupate hizo huduma kwa doorstep. Number 2 ni misdiagnosis yenye daktari amesema tu sahi sitarudia. Number 3 ni long queues. Unaweza patikana kama uko na unafikiria uko na ugonjwa, lakini ukianza ufike kwa matibabu unachukua muda mrefu kitabu kwanza ya matibabu. Like in my case nilianza 2017 kusikia niko na uvimbe kwa matiti, but nilikuja kuanza matibabu 2023. So wakati nilikuja kupatikana ilikuwa uvimbe kadogo, but kitabu nifikie kuanza matibabu ilikuwa stage 4. So you can see long queues. Like now ukienda Kenyatta uanze kusema tunataka CT scan, utabukiwa maybe August. Hata kama imeandikwa agency. Kidogo ya mwisho ni like ni mgonjwa wa Kenyatta. Kenyatta hakuna follow up kwa daktari. Unaweza pata daktari huyu, the next time ukiandikwa appointment utapata daktari tofauti. Na wakati tumebukiwa wote wanajua siku fulani wagonjwa fulani wanakuja. Ni vizuri wanaweza gawanyisha. ujue mimi nitaattend wagonjwa 10 ama wagonjwa 5 depending na hiyo list. Ndio at least ukuwe na follow up ya daktari wa mmoja. Unajua tuko na daktari anaweza kukufuatilia useme my doctor. Ya mwisho ni Kenyatta sahi wanafanya tu analog.
Yes.
Ni kufuatilia sahi ni files. So unaweza pata files zimemisplaced sababu ni wagonjwa ni wengi na files bado ziko mingi. Then unaweza patikana unatuma clinic fulani, the next minute unatuma clinic fulani. So file inapotea tu hapo katikati. Kama ingekuwa na system, at least ukienda kama mgonjwa kama mimi Esther, ukiklik tu hapo Esther utaonekana vizuri umetibiwa mpaka wapi na umefikisha wapi. Lakini unapata hata files zimepotea. Kama umefanywa test inabidi urudie sababu file haipatikani. So kuna hiyo mgonjwa mwenye hawezi pata hiyo nafasi ya kuweka hizo photocopies, una have to kulipa tena ndio ufanyiwe hizo tests. Na mwisho drugs ziko na shida kupatikana. Tuko tayari kumeza dawa but dawa hazipatikani. Ya mwisho ni SHA system ziko chini.
You know the question.
Ya mwisho
kabisa Esther. You know the questions truly are really too much here. But allow me, Linda, to just engage one other lady here in the audience who had questions for the Deputy DG.
Good evening, everyone. My name is Caroline Okere. I'm a caregiver and a cancer advocate. And I'm proud of all the cancer survivors in the house. Happy World Cancer Day. My first question goes to the Deputy DG about the SHA issue. We have people who had paid the upfront 2 years. Most of the patients had paid 2 years upfront with the NHIF. But when they go to seek services, they're told that their money is not in the system. So they are requested to pay again.
Let's have the mic up.
What happened to the money that paid? Like I have like 10 people who had paid up to 2026, sorry. What happens to their money? Because now some of them can't go for treatment. Number 2, this issue of SHA, the limit is 300,000 per person. We have patients who get medication and treatment of 100 per session. So this person has gone for 2 medications. She's not done the tests and everything. What happens to them after they exhaust the 300,000 limit? What happens to them? Number 3, we have the patients, they have their caregivers. For example, a caregiver loses a patient. What does the government intend to do with these caregivers so that this caregiver goes on with her or his life after losing this patient?
Okay, now I would like to throw that to our panelists to answer these burning questions, even as we let our viewers at home to know that they can join the conversation via our SMS line as well as our TV, social media platforms, with the question of the day being, je, umeathirika vipi na mzigo huu wa cancer? Over to you, Linda.
Joash will take it up. We go straight to the DJ.
Go straight to the DJ.
Okay. Yeah. Actually, there's a lot that has been said. I think just listening to what has been said over the long period of time that we've been seated, there is so much context that has come out of the discussants. But there are some direct questions that have been asked. And for me, I'd really like to start by saying that I think it's something that we are really concerned about, just to ensure, as I said before, that everyone is able to access high quality treatment at an affordable cost. So, Caroline, you've raised 3 issues. I think the first 2 I was able to understand. The third one probably you'll need to paraphrase. But what I can assure you is that we do not anticipate that there will be any losses in terms of switching from the NHIF platform to the SHIF platform. There have been some delays in terms of, crossing over. In fact, even now, we are still experiencing some challenges in terms of being able to move employees and so on between the two formats. However, the switch over does not anticipate. Actually, it does not just apply to assets alone, even liabilities. You know, the assets that are available will be moved over. The liabilities that are available will be moved over. There are so many things that are being taken up by the SHIFT platform, including even debts that were owed to hospitals, you know, by the NHIF. So I just want to echo what was said earlier by the chair of the Departmental Committee on Health in Parliament, to say that it is taking a bit longer for this process to now stabilize. Of course, we've seen a lot of stabilization from the beginning. It was much more rocky, but it is taking a bit longer. Initially, and I'll request that maybe I take 1 or 2 minutes here just to be able to bring some context out here. Initially, it was expected that, you know, the plan was very clear, because the plan was that we want to undertake a much more intensive program, which is not just going to focus on about 20% of the people, but is going to focus on about 100% of the people. So that is a big, massive shift. Number two, we were looking at a fairly new engagement where now we are not just saying that people pay a small amount of money, fixed, it doesn't matter how much you're earning, to now a prorated design where those who are earning more are going to pay more, those who are earning less are going to pay less. The indigents are not going to pay, they'll be paid for. So it is a complex scenario where now we were expecting that there were other pieces which are involved. It's a very complicated thing. It's not straightforward. There are other pieces that are very important in this whole scenario. For example, for this particular massive strategy to work, then we also want to substantially reduce the numbers of people who are seeking curative services. Yeah, we want to reduce the amount of money that is being deployed to curative services. And that's why we are now working towards bringing in a lot of investment to primary health care, health promotion, disease prevention, to drastically reduce the numbers of people who are attending hospital.
Dr. Terry, I want to come in. I want to come in even as you respond to that, and perhaps ask this question. That would take a collective approach to the concerns of health in the country. But just how is this uniquely fashioned to address the concern of cancer, which is what brings us tonight to this auditorium, such that then we can speak to them directly that are affected, bearing in mind that we continue to struggle with oncological centers, oncologists in the country. They stand at around 90 or thereabout. I stand corrected. I mean, how do we address this fashioned uniquely to cancer? Quickly.
Yeah, so generally this applies to almost across board, because what this program is intended to do is to be able to handle the public health issues. Now, you really have to get the context, because most of this conversation is usually fashioned in a way that looks a bit confrontational and combative, and it has been politicized and it has lost direction. But one of the things that you have to understand is that public health is a very interesting area. It is not just about government, just about the Ministry of Health. Public health is about all the stakeholders. It is about all the sectors that are involved. We are shifting from a clinical approach to a public health approach, where if somebody comes to the hospital with a fracture, we are not just concerned with the saying, let's go for x-ray, is it a simple fracture, is it compound, we put a plaster of Paris, are you in pain, painkillers, go home. Now we are asking, why is this person fractured? Then we find out maybe there was an accident. Why was the accident there? There is a pothole. So we bring in the transport people, say, fix the pothole so that we don't have more accidents happening. It's a holistic thing. So you'll find transport people are in there. Maybe the driver was drunk. The laws are not good. We want to bring in the lawmakers so that we address it holistically. Beyond and above government, we are also bringing in private sector. We are bringing in the community. It is a holistic thing. Everybody has a role to play. I think that is what I'm struggling to say. Just a minute. Just a minute.
We really want to group in the private sector.
Yeah, please allow me. Please allow me so that at least we can have a logical
Make it 30 seconds.
I'll try. Yeah, because these are also very...
Proceed.
Yeah, and probably also, if you allow me so that I can use the time to just bring it into context. So everybody has to plug in for this to work. Now remember, as we are trying to make sure that all these pieces are lined up so that it works, we were still expecting challenges, because this is moving from something that we are used to a massive kind of platform. However, we started encountering unforeseen challenges, you know, in the rollout. Started encountering unforeseen challenges. The honorable member talked about the design that SHA has taken, where we are having not just one fund, but 3 funds. We have a primary health care fund, we have a social health insurance fund, and we have an emergency, chronic, and critical illness fund. Now, when you look at these 3 funds, they are helping us to now move away from the NHIF design, where the benefit packages were open to abuse. So you find instead of the money going to help treat patients, they were going into building hospitals, putting infrastructure, investing in, it was going into other things. So the benefit packages have been clipped so that we now make sure that the money is going into treatment. Now, when the shift gets exhausted because the benefit packages have been shrunk, I know you've had people saying, we went there and we were told we can only be given 900 shillings. It's because of the design. The majority of the people with that condition will require that 900 shillings. But a few of them will require much more. And by the time it goes beyond that, then the ECCIF, the Emergency, Chronic, and Critical Illness Fund, kicks in, you see, so that we have fewer people who require even millions of shillings, but who will be paid for. So you see, it's a bit complicated. Now, what happened? Unfortunately, and the member talked about this, whereas SHIF is funded by premiums, the Primary Healthcare Fund and the Emergency, Chronic, and Critical Illness Funds are funded by the exchequer. They are not through the premiums. So what happened? The money that was supposed to go into these funds, which now reduce the number, the Primary Healthcare Fund reduces the number of people visiting hospital, and the ECCIF now deals with those unique cases which need very high amounts of money, were not capitalized because the instrument that was supposed to raise money to capitalize those funds was pulled out when we had the finance bill 2024 pulled out. So we were not able to capitalize the way it was anticipated. So that created a bit of a problem. Yeah. Now, bringing it to...
Dr. we must try to balance this.
I think I'm trying to answer the issue of limits so that we are on the same page.
Cut to chase. Make it short. Thank you.
Okay, so I think what I just wanted to say is that we are hoping that we can now be able to recalibrate, capitalize the 3 funds, the 2 funds especially, so that we can now have these other funds coming into play. And when that happens, by the way, we are anticipating that now those limits you're talking about, they are actually low. We are expecting that everybody who requires treatment is going to get that treatment. And in terms of losses, because of the shifts, that is not supposed to happen. It might take a bit of time, but then nobody is going to lose their money just because we are shifting from NHIF to SHIF. Thank you.
Thank you, Dr. for that. And I'm told we are taking a short commercial break. We'll be right back with more questions regarding the burden of cancer in the country.
elevate your business game.
As long as you're earning something, there's always that opportunity to save. And you start with where you are.
Kama wewe ni mfanyabiashara, huwezi kaa bure, unajipanga taratibu vile inavyofaa.
Join us each week as we dive into the stories of the world's most driven entrepreneurs.
When you pay attention to detail, you get luxury items.
The Grind, where business meets brilliance. Tune in every Monday at 7:30 p.m. because your business deserves the best.
Hey there, friends. Welcome to Kids on the Block, where fun and imagination come alive. We dive into magical world filled with exciting adventures and awesome friends.
What position were you in? I was number 2.
What position were you?
Number 1.
He decided to cross the bridge by his house and look for food on the other side.
We're going to do half cup of chocolate chips, and the other one, we're going to do half cup of the blueberries.
So, grab your imagination hats and get ready to explore with us. Join us every Saturday at 9 a.m. for new friends, amazing stories, and tons of laughter.
Join us as we explore the journeys of those who defy the odds and break barriers. We dive deep into the stories of triumph.
Sometimes when parenting a child with a special need or whatever disability, family life becomes a bit complicated and you may end up raising the child on your own.
Here, we inspire.
I have a farm which one we showcase with other dyslexic youths and autism how to farm.
Motivate.
It's never easy, but what we do, the best thing is to work with another parent who has an elder child than yours.
And break through the barriers one story at a time. Push your boundaries beyond the limit. Saturdays at 8 p.m.
Jiunge nasi tunapoangazia safari za viongozi bora. Kutoka kwa ushindi mkubwa hadi masomo magumu.
Wakati wetu kwamba wasichana si wa kusoma, ni wa kuolewa, ng'ombe ipatikane, wazazi wakuwa watajiri.
Tunashughulikia yote.
I wish I were a better investor.
My parents taught me how to look for things for myself.
Tazama Mfahamu Kiongozi, ambapo kila kipindi kimejaa maarifa, mikakati na hadithi za kukuza azma yako.
For me to succeed, I have to fight.
Kila Alhamisi saa 1:30.
Mtazamaji, tunaangazia mzigo wa saratani, na ni ugonjwa ambao umeweza kuangamiza wengi, wengine wakiathirika kwa njia moja au nyingine, labda kwa kutumia pesa nyingi katika kufanikisha matibabu. Na tunakujia mubashara kabisa kutoka ukumbi huu wa Chandaria katika chuo kikuu cha Nairobi, ili tukizungumza na wale wataalam na vile hathira ambayo wamekaa hapa ili kuweza kutupa hisia zao kuhusiana na masuala haya ya saratani. Na hapa mbele niko na wataalam, and now I would like to know from Prof, we are talking about the less funds or a deficit when it comes to funds in treating cancer. As oncologists, how are you managing the growing numbers of patients, especially when it comes to treatment?
To be fair, we're not managing. The people who suffer are in the audience. And the question becomes, it is easy to say we should prevent, but if you do not make mammography cheaper, pap smears cheaper, the vaccine cheaper, then even prevention does not work. So in many ways, the burden is then shifted from the government to the populace, and we are not managing well.
Thank you for that. And we've talked about misdiagnosis. We've talked about late diagnosis. What can we do as a country going forward?
You know, we are here at Nairobi University that has a medical school. We have a colleague here from Nairobi University. I heard all three patients talk about misdiagnosis by physicians who are trained in our country, who do mammographies, we do MRIs and CAT scans only to just push the patient another, kick the can down the road. So we need to go back for the Nairobi universities, Kenya University for that matter, Kenyatta University, to say, what is the curriculum of physicians that we train in this country? Is the medicine that we give to our physicians the best knowledge we have? Or is it that they forget so quickly that when the patient comes to the door, they just reap their money, their funds, but the poor patient is left to carry the bag? So then I was asked my colleague, what is the curriculum that we have in this country for training physicians to provide adequate care?
Anglican appears to be doing rather too well, without perhaps going into the details of what has been launched, a PET scan, and the activities that are playing out there. I think it paints a picture of just how the private sector is committed to this. Most of the times the government has been pointed fingers at, with the allegations that they are reactionary in nature, that when we find maybe a big person in society has lost their life to cancer, then we are all out there talking so much about this concern and how we're going to add oncological centers, how we're going to advance this and everything. What is this that we are perhaps not doing right, beyond the element of research, beyond the element of education, that perhaps maybe the private sector could be getting right compared to it? And why is it that we always then send our patients to India? What is this that they're doing that we are not doing?
You know, we need to understand, I come from AKU. It is a private, not-for-profit entity. 40% of our margins that we make are provided into, we talked about it here, into supporting those patients who do not have the means. Mm-hmm. I think the private sector is often very efficient. It is money-driven to be able to save money, but also save lives at the same time. So when we invest, for example, we heard the representative of the government says we put all these CAT scans and the PET scans and the SBRTs everywhere, but we do not have the resources. It's like having a machine gun, but no operator. Mm-hmm. The private sector asks the question a different way around. They say, before I invest in a big SBRT, what is the implementation science? What are the staff we need, the training we need, and who should be using SBRT to be very efficient? I think those are things that the government could learn from the private sector, in the sense that you are money conscious, efficient, and yes, you will make a profit. In the case of AKU, we turn the profit back to be able to help the resources of the patient that we serve. And I think everywhere you go in this world, the private sector has the efficiency model very right. But to be fair, the government has to deal with the entire populace. And the entire populace is often very impoverished, a very small percent of patients who can afford everything. So the government has a tough job to do. But I believe what we call public-private partnerships. We heard the government gave PET scans and CT scans to 4 centers. I've not seen the government give a CT scan to the Alcan University to say, here, we will donate this CT scan, teach us how to be efficient and make it better for our patients. So I would like to see more public-private partnerships that we can then show the government how to be more efficient and the government get from us how we can better serve the patient of this country.
We have CHPs, I believe, on the audience side. I would love for them to as well highlight just what then we need to do in terms of addressing these concerns of cancer and health at that primary level, vertical ground. So Sheila, before we come back to you, I think we have a question for Phoebe.
Phoebe, we've talked about the burden that is there, and we know when you work for KENCO, there are several organizations that you work with, and I earlier asked you about the same. So here we are talking about the burden that we have going forward, and also looking forward for eradicating mostly cervical cancer, as it is as per the World Health Organization. What are you doing as an organization to ensure we reach that goal?
And Phoebe, to add on to what it is that Onsare speaks of, I would love for you to as well highlight the concerns that come along with the mental torture and the drain that, of course, everybody gets to encounter, you know, caregivers as well as cancer patients, and not forgetting just how then we can loop in society as well to ensure that this then is addressed. We shun out stigma because it comes along with the same.
Thank you very much. Let me just start with what he has asked about the burden. Every day we are losing 10 women to cervical cancer, and yet this is the only cancer that can be prevented completely through vaccination and also through early diagnosis and screening. So what we are doing, we are really, we applaud the government for what they are doing with the HPV vaccination. And I think Ministry of Health is currently working on having a single dose vaccine for the 9 to 14-year-old. So as a CSOs, what we do is to amplify such. So currently we are doing a lot of awareness and training for the girls between 9 to 14 years, but we are calling for multi-sectoral engagements. We need the clerics, we need Ministry of Education, we need the patients, we need the parents, we need the teachers, we need the peer education club, so that everyone is on board to ensure that this burden goes down. One of the reasons why HIV project succeeded was because what we call patient experts. So these patient experts were patients who are actually living with HIV, who are involved now to do the community health promotion and all that. So we are pushing that the same. As you hear, these are patients with lived experience. They know better on early screening. They know better on patient navigation. They know better on when to seek for treatment. We are urging that even as you recruit the community health promoters in the communities, let us consider the patients with lived experience, because they know it better, and they will do it from a peer-to-peer kind of approach. And just to overemphasize the importance of mental health. Most of the times in cancer care, we look at mental health towards the treatment, but we're emphasizing that mental health is so important right from diagnosis. As you go for that biopsy, there is fear, there's anxiety. We need to have it, the trained personnel, either the person doing the biopsy or healthcare workers or counselors who will take this patient through it. Because when a patient is mentally unstable, they will not adhere to medication. When they are mentally unstable, they will not have the quality of life that is concerned. So it is very important that we incorporate mental health, not only at the end or in the middle, but from the beginning. And it's important that all healthcare workers, and again, not overemphasize the ability of the lived experience patients who with mental health capacity and knowledge to navigate these patients right from biopsy to diagnosis and to treatment.
Of course, we come to you, and we are curious, when we're talking about quality treatment, when you're talking about what the future is like, when we're talking about care in general, where does research come in? Because I'm assuming that in the process of research, we want to look at participatory approaches. We want to look at the situation locally, but we also want to look at, you know, say the bigger brothers, other countries. We have statistics here. We are not doing good, but at the same time, if you compare to other continents, we are at 50-something%, which is perhaps fairly better than them, you know. So then one would want to ask, just how then does research come in to ensure that we are serviced with all this information and that we are well placed to address the concern of treatment and care?
Actually cuts across the entire pathway, the entire patient pathway, right from diagnosis to treatment to prevention. It cuts across all those sectors. So research should be a part and parcel of care, right? So that we can even evaluate the treatment that the patients are being given. You know, we need to be able to monitor, to do evaluation, to assess, to see, are we even making an impact? Even the therapies that you're providing, what is the outcome of the therapies that they are being given? So we need to be able to evaluate that. So research will be a part and parcel of the entire pathway along, along the care pathway, from when the patient is diagnosed all the way to treatment, to know the survival, to know the outcomes. It should be part and parcel of that. But in most cases, we are not doing that because, of course, as you've heard, there is limited resources for research. So that is usually the biggest challenge. But essentially, it's supposed to be, you know, part of the health systems. You should be even analyzing the health system to see, is our system serving our patients? You know, there should be research on health system. There should be research on prevention, on risk factors. You know, when a patient is diagnosed with cancer, it shouldn't just be, okay, we need to treat. But we also need to ask the question, why did this patient have cancer? Right? And be able then to look back and look at the risk factors to be able to address that. So the research really should be a part and parcel of the entire care of the patient that we are serving. I think we've heard also from our audience about the many challenges that come into play, the misdiagnosis, you know, the long waiting queues. What can we do so that then we can be able to reduce the burden? Dr. has talked about public-private partnership, right? Right now, yes, we have the treatment machines, but you find that there are long waiting times. You know, someone has to wait for 4 months. For example, in KUTRH, they have to wait for a long period of time to access treatment. So how can we partner, maybe with the private sector, so that those long waiting queues can be reduced and we can utilize even the resources of the private sector? So these are conversations then that the government and the private sector can have, so that if patients are onboarded on SHA and they go to Aga Khan Hospital, they can still access radiotherapy as opposed to waiting for 4 months to be able to access that in a government facility. So I think those are some of the conversations we need to have. The World Cancer Day theme emphasizes on action, taking action. What kind of action are we taking as government? What kind of action are we taking as healthcare providers? Why should patients be referred several times before they're diagnosed with cancer, right? So we need to be able to evaluate ourselves. We need to be able to assess how are we serving our patients, so that if a patient is being diagnosed at a community level or at the county level, sub-county level, they should not be, you know, taken back and forth along the care system before they're actually, you know, moved to the right place. And it also takes, you know, us also as individuals, we also need to be able to take action to say, I have gone to this facility, I've not gotten the care, should I move to the next facility? So as individuals as well, taking action to ensure that we are taking charge when it comes to our health. So we need to be able to evaluate our health systems, we need to be able to assess, we need to be able to put funds so that then researchers are working together with the clinicians and being able then to do research that affect or rather impact on the outcome of the patients.
I am curious, maybe just to loop in Daktari, and perhaps in relation to that, that most of the Kenyans will tell you that any time they have dreamt of traveling to India or maybe abroad, it is because of a health concern and cancer, to be precise. Let me just make a correction here and talk about the numbers in terms of the continent, that Asia stands at 49.2%, Europe stands at 22.4%, North America stands at 13.4%, Latin America and Caribbean stand at 7.8%. Let's come to Africa, where we stand at 5.9%, not 50, as I had said earlier on. So 5.9%. And then in terms of research, I want to trust that maybe this has triggered the minds of researchers to figure out why is it that we always have to find ourselves traveling abroad, in as much as we understand that maybe the situation in terms of health in the country is not at its best. But do we even have Kenyans that have the confidence and the belief that they can get the best of healthcare in the country, even as we struggle to advance?
Thank you very much. I think I'm not going to belabor the issue of misdiagnosis and quality of training. You see, I think there was a race to address the doctor-patient ratio, the doctor-population ratio, and therefore there was ballooning of universities, recruitment of so many students that, as it is, outstretched the capacity to train. So, but that is something that is being addressed. So the issues of misdiagnosis, I think those ones are isolated cases. Generally, I think Kenyan doctors, the majority are able to make a diagnosis. So I think one case should not discourage us. Two, I think at the University of Nairobi, we have a curriculum that is quite elaborate to train doctors to address the health challenges. And we have two such programs, that is the medical oncology fellowship and the radiation oncology fellowships, because we noted that there was a huge gap in terms of well-trained personnel to address the diagnosis of cancer. And the diagnosis of cancer sometimes is not straightforward, and it requires a system that is not only present but ready. The readiness of the system is very important. If you look at the the health facilities, there are almost 3,000 or so health facilities in Kenya, and you ask yourself how many of those facilities have the histology, pathology specific for cancer, which we call histological process. How many of those facilities? You'll find is less than 10%. So you have well-trained doctors. And actually, even if you look at the number that go to India, it is only that it is highlighted. When one person goes to India, thousands are likely to know that so-and-so went to India and was treated and got cured. But the ones that we cure here in Kenya are rarely talked about. So I think the first thing we need to do is to really do what Anne was talking about. Let us reevaluate the services that we provide and translate this to a way that the populace is able to understand. Because the general feeling is that if you have cancer and you are getting treatment in Kenya, you are getting substandard treatment, and that if you had the means, you will go to India. Yeah. Yet we know that we are able to achieve much, and Kenya actually has well-trained medical, radiation, hemato-oncologists who are able to respond to the cancer burden if the system is quite responsive and is able to address those issues. Now, Dr. Matendechero, when we sit with these patients in the clinic and they come and tell us that Shah has told me I cannot access care anymore, we feel a lot of pain. And, these are the cases that go out there, progressive disease, get very negative report about Kenyan patients. Now, India has a model that I think attracts patients. And this is a comprehensive care where you have the bits and pieces of care that is needed to manage a patient in one sort of establishment. That is something that we lack. And the case that is being shared here by our cancer survivors is a testament to that. You need to see a radiologist, you're sent somewhere. You need to see a counselor, you're sent somewhere else. You need to see a nutritionist, you're sent somewhere else. So you do a lot of walking, and if you do not have a navigator, then these patients get lost in between. And in India, what they tell you is when they enter a clinical scenario, the surgeon is close by, the medical oncologist is close by, the radiation oncologist is close by. So the decision is made within the short period of time that is required. Now, the documents are in Afya House about comprehensive cancer centers. As we speak, we only have, I think, about 2 or 3 comprehensive cancer centers, yes, 6, in the public space. They are all in major towns, serving 20% of the population. We have 80% who cannot access the comprehensive cancer services.
Asante sana Daktari Omondi. Na mtazamaji, tunaendelea na kikao, na kama ndo mwanzo unajiunga nasi, tunaendelea kudadavua swala hili la saratani ili tuweze kufahamu fika mzigo huu unatoka wapi na ni vipi tutapata suluhu ya kuweza kupata tiba mwafaka kwa changamoto ambazo zinatokana na saratani. Na vile vile mwandishi wetu ambaye mwanahabari mwenza ambaye ni Sheilar Chelangat anaendelea kutangamana na Wakenya ambao ni washikadau wakuu. Kuna wataalamu wa lishe, kuna watafiti na vile vile kuna wale maafisa wa afya nyanjani maarufu CHPs. Sheilar, nakupa usukani, washirikishe pia.
All right. Thank you very much, Joash, Onsare. And just before we engage the audience, the panelists are speaking about access to these cancer treatment centers. And oftentimes in the villages, they can access the community health promoters. So let's get to hear from a CHP. Are you trained in matters cancer care? Are you empowered enough that now you can be able to see some of these symptoms and help in the detection and diagnosis of cancer?
Thank you very much. My name is Agnes Njoki from Umoja Health Center. I'm a CHP. When we call ourselves CHP, these are the community, well-trained community health providers who give basic care to the community, educate them, and also educate them. When it comes to the matter of the community, you know, these are so many people we are dealing with. And there are so many challenges we face in the community. Because these people, we get them in different ways, different beliefs and the way they see things. When I talk about challenges, let me start with the challenges we face as the community health promoters to the community. These people, they educate themselves before you educate them. And the challenges we get is before you go tell them about the good thing and the better thing of the getting tested of cancer before it gets too far, they start challenging you. I'll talk first of all about this HPV virus and the injection. This is something that we are getting a lot of challenges in the community. These people, they have come up with some ideas that this is a family planning, this is something that will stop our girls from getting pregnant, and for them to give them the correct information that this is something that will prevent the girls from getting cancer. You have to take a lot of time. One thing about the community, it comes with so many aspects. People come from different places to come and educate them. There are so many groups that form themselves in the community, telling them that this is a healthy way for their girls to get the proper and to get prevented from cancer. You'll have to take a lot of time.
Right.
I would urge the government, and especially the Dr. Sultana, I would urge the government to give us free medical camps, especially in our community, where doctors can come and educate these people. For us, they see a community health worker. Yes, we are well trained, but when it comes to the matter of cancer, this is somewhere they cannot gamble. They want to hear from a doctor, an oncologist, that if I get this injection, I'll prevent my daughter from getting this virus. So if the government can give us the camps, the free medical camps, severally, many times, come to the community, educate them. Us as the community health workers, we shall mobilize this community. The good thing we can do to you doctors is mobilize these people for you.
Right.
Then you can come and you educate them. If they hear from you, they'll know the goodness of this injection.
Mm-hmm.
Because in the community, before they agree on something, they have to get it from the live person.
Right.
Yes, we try our best to do it. But we need a doctor. We need camps. We need so many free medical camps.
Mm-hmm.
And make it free. Because in the community, they are those vulnerable. If you tell them about HPV is free, they will say, if you go to the community and if they charge us, before you tell them that this is a free injection, it's a very difficult thing for them to believe.
Okay, allow me to cut you short there. Indeed, there seems to be there a need for a lot of sensitization of the community. And when we will be back after this short commercial break, we will take a quick fire round of questions for our panelists as we discuss the larger burden of cancer in Kenya. Do not go too far. Keep it TV47.
Are you ready to elevate your business game?
As long as you're earning something, there's always that opportunity to save. And you start with where you are.
Kama wewe ni mfanyabiashara, huwezi kaa bure, unajipanga taratibu vile inavyofaa.
Join us each week as we dive into the stories of the world's most driven entrepreneurs.
When you pay attention to detail, you get luxury items.
The Grind, where business meets brilliance. Tune in every Monday at 7:30 p.m. because your business deserves the best.
Hey there, friends. Welcome to Kids on the Block, where fun and imagination come alive. We dive into magical world filled with exciting adventures and awesome friends.
What position were you in? I was number 2.
What position were you?
Number 1.
He decided to cross the bridge by his house and look for food on the other side.
We're going to do half cup of chocolate chips, and the other one, we're going to do half cup of the blueberries.
So, grab your imagination hats and get ready to explore with us. Join us every Saturday at 9 a.m. for new friends, amazing stories, and tons of laughter.
Join us as we explore the journeys of those who defy the odds and break barriers. We dive deep into the stories of triumph.
Sometimes when parenting a child with a special need or whatever disability, family life becomes a bit complicated and you may end up raising the child on your own.
Here, we inspire.
I have a farm which one we showcase with other dyslexic youths and autism how to farm.
Motivate.
It's never easy, but what we do, the best thing is to work with another parent who has an elder child than yours.
And break through the barriers one story at a time.
All right, welcome back. This is Kikao as we continue the conversation of the cancer burden in Kenya. And just before the break, I was engaging the audience, and CHP raised a fundamental question on sensitization. But then cancer also comes with a lot of lifestyle changes. So what are some of the people who are undergoing medication having to now change in terms of their lifestyle? So let me engage Rose, who is a survivor, who underwent treatment, got well, and is better now. But Rose, while you were on treatment, what was some of the changes that you had to make?
Okay, naitwa Rose Adero, cervical cancer survivor. Pia the founder kwa group by the name Jidhamini Shujaa. Jidhamini Shujaa ni group ya cancer patient, survivor and caregiver. Mi chenye naweza kusema after treatment ya cancer, life haiwezi kurudi the same. Kwa sababu tunapitia a lot, tunatumia fedha nyingi, kama mimi wakati nilikuwa nilitibiwa private hospital, sikuchagua, but sikuwa na choice kwa sababu nilienda government hospital, nikaambiwa nilipatikana mwaka wa 2015, lakini venye nilienda government hospital niliambiwa nafasi nitapata 2016. Na kulingana na daktari alikuwa ameniambia nianze treatment as soon as possible. So sikuwa na choice, niliavu kwenda private hospital.
Okay. And in terms of the diet, did your diet change while you were on treatment and even after treatment?
Okay, after treatment diet ili change, but wakati nilikuwa naendelea na treatment, oncologist aliniambia ninaweza kula anything kwa sababu treatment ya cancer sio rahisi. So nilikuwa ninakula chochote chenye ningepata, but after treatment diet yangu ili change.
Okay, let me take this conversation now to the nutritionists in the house. Please pass the mic down to our nutritionist here. What is the nutritional advice that you'd give now these people who are on cancer treatment, and even those who are, have finished the cancer treatment? What is the advice, especially on diet? What are some of the changes that they do have to make in order to, get better?
Okay, thank you for the opportunity. There's a lot that we do as nutritionists. First, we do assessments once the patient is brought to our care. We do assessments, we do diagnosis as nutritionists. Then we go ahead and check their body composition. Once we see the body composition, then now we can advise. There are doctors that say eat anything, but remember, once you are diagnosed, the body is really breaking down fast and you really need lots of protein. Talking about protein, you really need to talk about how are you making this protein, because maybe you can be adding some more carcinogens in your body, the cancer substances. So you really need to talk to a nutritionist to guide you in preparation, portion, and even the frequency of whatever you're eating.
All right. Thank you for that. But also
One more, sorry.
Okay.
And maybe to add on that, this goes to our Deputy Director.
Could you introduce yourself, please?
My name is Lilian Mumina. I'm a nutritionist, and I'm also the National Treasurer of the Kenya Union of Nutritionists and Dietitians. So we have emphasized a lot on the curative aspect of management of cancer, and all our key problem has come from funding. From the cancer survivors, from even the researchers, they have actually highlighted the need of increased funding when it comes to cancer management. But there's also the aspect that we are ignoring as a country, and that is the preventive aspect of disease. And this is where professionals like nutritionists, as we have had a patient who has said that she was diagnosed and then she was told that she can just have anything while on treatment. And as we understand the side effects of cancer treatment, the chemo, the radiotherapy, they come with all these complications that actually affect the adjustments is definitely a must. So when we ignore key providers like nutritionists at the community level, our CHP has said that one of the key challenges that they actually face when they go to the community is the negligence or the ignorance of those community members that they insist they are not professionals. Why are we not utilizing what we already have as a country to actually work on what we are actually facing? Things like adequate dietary adjustment, public health prevention activities, and I understand that the Ministry of Health has nutrition highly impacted or written on their policies, and unfortunately those policies are just that, policies on the shelves. And our Professor Congo, in his speech yesterday, highlighted that 75% of all the challenges that we have in Kenya don't need new policies. They don't even need new resources. They just need appropriations and prioritization of the funds that we have and the implementations of the policies, as we, of course, we are going to renew because of the current trends and the changing trends that are already existing. So maybe, Daktari, you can tell us going forward what you are going to do for the Kenyan population when it comes to the preventive aspect of diet in managing and preventing the surging numbers of cancers.
Okay.
Thank you.
Thank you. We do have an oncologist here amongst us in the audience, Dr. Premier Suching. Are there any preventative measures that can be taken towards cancer?
Thanks so much, Sheilar, and thanks for giving me the opportunity to talk about the prevention. So, as said before, we have many cancers. And cancers, the only place where cancer never attacks is your hair and your nail. But again, most of these cancers that we have, many of them may not be prevented. We have a few that we can prevent, and the few that we can prevent are the ones which are very common. Well, prevention simply means stopping it from you getting it, and most cancers have risk factors. As said by Professor Mansour before, we start with cervix. If you are in Kenyatta, and most of the public hospital, KU and Kenyatta, the number one cancer is cervix, and cervix is preventable. How do you prevent it? It is caused by HPV. Majority of the cases, almost 98-97%. So if you get HPV, then vaccine, then it prevents you from getting HPV when you are exposed to it, and so that is one of the major prevention of cancer cervix. Diet has been known. We know cancer is a disease of genes, cancer is a disease of environment, cancer is a disease of the metabolism. And again, it has not been very, very clear. We know there are certain risk factors which actually are known to cause cancers, but then diet and that has not been very clear. There are a lot of controversy about it. We know smoking is a big risk factor of many cancers, ranging from even cervix itself, lung, larynx, bladder, pancreas, and so forth. So stopping smoking prevents you from getting. The other one is alcohol. We don't say don't take alcohol, but excessive use of alcohol can actually, you can prevent most of the cancers.
All right. Thank you very much, Dr. Premier Suching, who is an oncologist. For now, I want to take a quick fire round of questions here in the audience, and let's begin with the gentleman seated next to Caroline. You had a quick fire question. In 30 seconds, please ask your question to our panelist.
I'll take 15 seconds. My name is Elo Mapelu from the Kenyan Network of Cancer Organizations, and I will not leave this place happy if I don't get a response from Dr. Sultani Matendechero. You said that the instruments that were supposed to operationalize the critical illness fund are not there. So we don't have that critical illness fund in this budget cycle. My question is, in the absence of that, are we just going to be seeing patients die? Because otherwise they will not be able to get treatment after they exhaust their shift cover. What is the government doing to make sure that we are preventing these deaths? Because they are definitely going to be if we don't have a way out of that.
Okay, Dr. Sultan, could we get an answer, a response in 15 seconds too?
Problem is, because we have, in fact, you've gotten it out of context. Now I'm supposed to answer in 15 seconds.
Okay.
I said the instrument that was to raise money to operationalize the two funds was withdrawn. You are aware what happened in June. The finance bill was withdrawn, so money could not be raised. However, patients are still being seen. They are not being given. It is not happening the way it was expected. So something is being done about it. But we are hoping that in the fullness of time, we will be able to recalibrate. That's what I said. And I also want to repeat for the 18th time, it is not about the Ministry of Health against everyone else. I said everybody has a role to play in this. It can never work. You can never sit in a corner and start saying, private sector, we want you to do this. Oh, citizens, we want you to do this. Everybody, we want you to do this. It is not possible. We have to find out what is my role in this, because it is not business as usual.
Okay.
You have to find out, you have to be proactive, you have to be positive, so that we work towards a solution. This is a very big problem that has to involve everybody. And I can tell you, those policies that we are saying are sitting on the shelves, they have provided for most of what we are talking about here. What we need to find out is, how do we operationalize? What is my role? What is the role of the county government in operationalizing?
Okay.
What is the role of each and every player in operationalizing these policies?
All right.
That way we will move forward. But if we just resign to trying to look at, okay, so now you have the policies. Now how are you going to operationalize? You have the vaccines. They are going to cause childlessness. Come and persuade us to take the vaccines. We will never work
I
that
hope
way.
that response
Everybody
suffices.
has to play their role in making this work.
Does it suffice?
Yeah.
Okay, that is 15 seconds. I will get to you back to you. But let me get a question from this end. What is your question tonight?
Everyone, my name is John Wangare. I'm a pancreatic cancer survivor for 13 years. I got a baby even after that, and I thank God for that. My doctor is here. Dr. Ochieng was my doctor. So my question is, in the 13 years that I have survived pancreatic cancer, which is one of the hardest types of cancer in this country, no one has ever reached to me to know the cause of my survival rates for those years, which can help other patients who are coming up. Like right now, I have a lot of patients reaching me out, telling me that they have pancreatic cancer and it is at advanced stage, they don't know what to do. But according to the people, the researchers, they should have a way of coming to the patient and looking of a way of coming up with a solution. So another question, let me emphasize on this. The last question is, mmesema ya kwamba mambo ya SHA, you have talked about SHA, but kwa nini hakuna madawa hospitalini? We have asked that question several times. Kwa nini hakuna madawa ya chemotherapy in government hospitals?
All right.
But we have them in private hospitals. Unatumwa kwa daktari huyu wa private hospital, unapata zile dawa ziko huko. Kwa nini hakuna kwa madawa?
All right, and I will put you again on the burning seat, Dr. Sultan. Why don't we have medicines in our public facilities? Why are they only there in the private institutions?
So we don't have a good, supply of medicines. That is something that is obvious in the public hospitals.
The question is how?
Pardon?
How do we not have a good supply of these medicines?
No, we are saying that's the situation that is that has been there. Yeah. Now you see, this is what I was talking about. why are we looking like now we want to make it look like it's our. So you see, I talked about universal health coverage. It has 4 pillars. One of the pillars is health products and technologies, not just medicines, but all the supplies, equipment, and other facilities that we need to be able to use in treatment. And there is a whole plan. In fact, it involves things like recapitalization of KEMSA, so that we can be able to have these medicines in the hospital.
Okay.
Yeah.
All right.
So now you are done. You just wanted to ask the question.
No,
then
we are getting
then
to
people make noise and then it
Dr.
looks
Sultan.
like now there's
Let me get to you, Anne, on the issue of research. Why do you not get to the patients and find out the survival rates? Why is that?
Actually, we have studies that look into survival. We've done studies on breast cancer. We've done studies on cervical cancer, prostate cancer. And I'm really glad to hear about pancreatic and 13-year survival. That is really great. And most likely it has to do with early detection, effective treatment. And definitely for us researchers, we will be very interested in getting more information from you and others who have had such success stories. So yes, we've done a lot of studies on survival, and there are very good outcomes when you diagnose them early. Stage 1, stage 2, as I mentioned earlier, the survival rates are very, very good. But if you diagnose them late, stage 3, stage 4, that's when we have very poor outcomes.
Okay, before we get to your final thoughts, I want one question from a young guy here. Please shoot your question in 15 seconds.
Okay, my name is Edwin Austin. I am a graduate researcher here at the University of Nairobi. First of all, on the survival rates, it's actually to this point,
Please hold up your microphone.
20% of cancer survivors actually live up past the 20-year mark, which now brings me to my question, which will probably be best answered by the oncologist or the researcher from the University of Nairobi. We speak so much about preventative measures of cancer. What is stopping us from finding a cure? When smallpox was the greatest, should I say, disease back in the second half of the 20th century, so many researchers took up the matter and actually solved it, although over 300 million lives were lost. In the 21st century, allow me to point out COVID, although I'm not drawing parallels between cancer and COVID. It brought about the concerted effort of the whole world to find a vaccine in less than what? Was it 1.5 years? We already had a vaccine. We are in the at time when we have state-of-the-art technology, the best oncologists in the world. What is stopping us from finding a cure for cancer?
Okay, Professor Mansour, could you take that up? Why are we not having a vaccine for cancer yet?
So let me answer this very quickly because you guys are running out of time. The polio vaccine is one virus with one antigen. The COVID virus is one virus with one antigen through which it enters your body and infects you. Cancer, the human genome is thousands of genes, each of which can mutate and cause cancer. We do not have one solution for the genetic makeup of the human beings that get mutated. Just to give you a quick example, we talk about research. We took tissue from women from Kenya, Kenya University Hospital, with triple negative aggressive breast cancer. Compared it to African American women from the US and Caucasian women from the US. We had many more genes which are different than those same women with the same cancers in a different country. So even the ethnicity of our patients have a different makeup and causes a different form of mutation that results in cancer. So we cannot have a solution for a multitude of genes and have an example of polio or COVID. HIV, do we have a vaccine for HIV? The HIV virus mutates every 20 minutes. Every 20 minutes, that virus looks different than it was 20 minutes ago. We don't have a vaccine for it. And just the same way, it would be difficult to have a vaccine for the entire cancers. But when the cancer is caused by HPV, one virus, we have a great vaccine. I think that is the answer.
Okay. Quite an answer. I hope it does gives you some sort of insight on that particular issue. For a second, nutritionist Joyce, could you tell us, could you shoot your question?
Mine is not really a question. Thank you. My name is Joyce. I'm a clinical dietitian nutritionist. I'd like to respond to what the Daktari back there said about nutrition and not being conclusive in prevention of cancer. We know that once you have a habit of overeating or eating too many carbohydrates, that brings obesity. Obesity brings about 1 million cancers, from breast cancer to esophagus cancer to liver cancer to kidney cancer, and that is just from diet alone. There's a patient also who said they were constipated and later on led to other series of tests, which finally they have cancer. Constipation stems from diet. What are you eating? Why are you constipated? Again, that goes to diet. You can prevent constipation. So if you have a lot of water, have fiber, then you're preventing the cancers that come with constipation. Okay. So we check a lot on diet, and diet is very conclusive when we talk about preventing cancer, treating cancer, management. There's a lot a dietitian can do than just rubbing them off and telling them that diet does not do anything in cancer. Thank you. All right.
Thank you very much for your questions, your feedback and comments. But for now, let me hand over to Joash Onsare, who will now further engage the panelists.
Asante sana Sheilar Chelangat kwa kushirikisha pia wadau kuhusiana na swala hili, na hapa mbele sasa tuzungumze kauli za mwisho na wataalamu ambao tuko nao, tusikie kauli zao za mwisho tunapotamatisha. Na kwanza kabisa ningependa kuanza na Eunice. Kauli zako za mwisho kuhusiana na kampeni hii, hamasisho hii ya saratani ni ipi tunapokamilisha?
Asante sana. So one of the things I would also like to highlight, as Daktari has said, the government cannot solve all the problems. And this coming from my own personal experience, when I got my second diagnosis, I had insurance, a private cover. But when it was time to renew it, they dropped me. And this is because they termed me as high risk. So when it comes to now medical care accessibility, then I'm forced to just rely on SHIF alone, because even if I can purchase that premium cover, I'm not allowed to. I've applied to countless times. I've applied to private covers, and they do not allow us, to get the cover. So what I would say is we need to come up with a holistic solution from the government, the private sector, to make their services more affordable for us. Now, the insurance companies to give us this cover so that we can actually have a better chances at fighting for our lives. Thank you.
Shukran sana, Eunice Mwende. Prof. Mansour, what are your final remarks?
It takes a village to change this, and I go back and echo what the DJ said. It is our responsibility. So I go look at the young woman who survived 13 years of pancreatic cancer, and I applaud her because we lose most of our patients with pancreatic cancer. And my question to her is, would she not come to the registry and say, here, I have survived 13 years, check my gene, I might have something that you could sell and make money. So my sense is that is our responsibility. So don't put the poor man on the stand. All of us are responsible, and yes, we can. Barack Obama, my president, and I'm an American. I came here from America 5 years ago to do work in Africa because I was born here. My president says, yes, we can. And we can collectively, not individually. Many issues on the government for sure, but we voted the government in. So we might as well take the responsibility for it as well and try to help them solve our issues.
Well said. Thank you so much. Dr. Omondi, ungependa kusema kipi ama ushauri wako ni upi kwa wale ambao unafundisha? Najua umekuwa pale darasani ukifundisha wataalamu wengine. Ujumbe wako ni upi?
Thank you very much. I think Kenya is ours. We are in it together. The solutions are going to come from us, not from anyone else. For those of us who are in research, in training like myself, I think let us take our responsibilities seriously. And the DG, my friend, you have said that each of us should do something and not just look at the government, which we are part of. My question is my monthly contribution part of that responsibility that I have, or there's something else I need to do so that SHA can work? I contribute every month. Is there something else that I need to do so that SHA can work? Thank you.
Beautiful. Yes. Yes. So we are marking World Cancer Day today, and the theme for this year's World Cancer Day is united by unique. Essentially what it's saying is we are all unique. We all have unique experiences, but we need to be united in the fight against cancer. We all need to take responsibility for our actions. We need to take actions. I think we've talked so much about SHA, and it is not just the government. It's all of us, taking action and ensuring that we are really fighting this menace called cancer. For us as researchers, we are really still emphasizing on funding from government, local funding towards research. If you look at developed countries, they invest so much in research, right? KEMRI is an institution that doesn't just deal with cancer, it deals with so many other conditions, viruses, malaria, and all the others. So the little funding we get from government is divided in all that. So cancer is still left out. It doesn't have much funding to do the kind of research you want to do, the genomics, the omics, and all the kind of research you want to do. So we are still calling on government to put in more funding. But as we celebrate this World Cancer Day, we stand with the survivors. Thank you for your very beautiful stories of success in the treatments. We really stand with you, and we ask that we all work together in the fight against this cancer. Thank you.
Shukran sana Daktari. And Phoebe, najua kuna wale wagonjwa ambao wanajipambania wenyewe na nyinyi kama mashirika. Labda wito wako ni upi kwa wagonjwa ambao ni wa saratani na wale ambao washapambana na mwisho wa siku kuna tabasamu?
Tunasema kwamba ungana na support group ili utie moyo wale ambao pia wanapambana na hali hiyo. When you join the support groups, when you share your story, you've had most of the patients, and if you look at them, you hear stage 4, stage 3, those, and they're looking very healthy. When a patient survivor walks in and says, I have lived with cancer for 13 years, that alone is a testimony. So once you survive this, you know the journey, you know the challenges. And I'm so happy that most of the patients who survive, they usually come out with something. They start organizations, they start support groups, they start CBOs, and that way they're able to fulfill. So my take-home message is that let us enhance community-based screening. The top 3 killers of cancer, prostate, cervical, breast, can be prevented, and yet the uptake of screening is very low. Prostate, for example, wanaume tafadhali 4.4% is not our portion. That is too low. When we enhance community-based screening so that more men come out, cervical cancer now it's improving around 20% uptake of screening. Breast cancer is now regional. In the villages, it's very low, from 8%, 12%, and 20% in the villages. And now finally, the UHC document that Dr. Matirere talked about is very good on paper. Actually, the people who wrote it had very good plans for this country. I hope that one day it comes to pass. The PHC, the SHIF, and the critical fund. But now, let that, whatever is on paper, come down to the ground. Kwa sababu kwa ground, vitu ni different.
Asante, shukrani kwa kauli yako.
Daktari, serikali saidia.
Sasa wewe funga.
Itoke kwa karatasi. Okay. So, first of all, thank you very much for this opportunity, and I think this is the essence of having these World Health Days, to just advocate for better ways in which we can be able to manage these problems. So today I think we've done quite well in terms of creating awareness around cancer and encouraging all the stakeholders to come in and work together. Cancer is a very big issue. We have to pull together, work together, talk to each other, listen to each other, so that we can find solutions. If we talk at each other, we will not be able to manage to do this. Now, I have to take an opportunity to just say, let us support the plan to be able to make healthcare available to all. For those of us who have not registered, let us register for SHA. For those of us who know others who have not registered, let us encourage them to register so that we can all be in it. And then finally, as I heard you talk, I remembered something about our mechanisms, the ways in which we justify our requests for funding. I suffered a lot of that before, and I could see that probably you are a culprit of the same. So talk to me after this. I will give you the trick on how to unlock the funding towards research, because actually research is very important. It helps us to be more efficient so that we can get better results even as we roll out our health programs. Thank you very much.
Thank you so much. Last speaker, Dr. Sultani Matendicheru, and that is Senior Deputy Director, Ministry of Health, Asante Sana, as well as right next to him, Phoebe Ongadi, Executive Director, Kenya Network of Cancer Organizations, as well as Ann Korir, the Head Nairobi Cancer Registry, Senior Research Scientist, as well as Cancer Epidemiologist at KEMRI. And of course, right next to her is Dr. Onyiro Omondi, Lecturer, Department of Internal Medicine, University of Nairobi, and not forgetting Professor Mansour Saleh, Chair, Department of Hematology Oncology, Aga Khan University Hospital of Nairobi. You know, Obama is also our president, eh? You understand why. Thank you so much. And of course, the lady of the moment and many other survivors right here.
KEMRI Annual Scientific Conference happening on the 11th to the 14th, because there will be a lot that will be shared from the findings from research.
Beautiful. We'll send our invoice for the advertisement as well. Yeah? Thank you so much. And Eunice Mwende, cancer survivor, as well as very many other cancer survivors here who've shared their stories this evening. We appreciate you, and as well the entire audience. I know we did not get to speak, all of us, but we appreciate that you made time to be here. Onsare, over to you.
Shukran sana Linda Alela, najua mara nyingi hatujishukuru. Asante sana Linda Alela, asante sana Sheilar Chelangat na kikosi kizima ambacho kimefanikisha shughuli nzima, na ni furaha yetu kila wakati kuangazia masuala haya ambayo yanakuhusu kwa njia moja au nyingine, na tutahakikisha kama TV47 tunafanikisha yote kwa jumla, si elimu, si afya, si teknolojia, si kilimo, yote kwa pamoja, ili uweze kufahamu masuala haya, kwa kuwa tunasema yanakuhusu kwa njia moja au nyingine.
Kuna mama pale ni kama kidogo ana jambo la kusema, dakika sekunde 30 tusije tukauawa. Microphone karibu.
Asanteni sana. Kwa jina naitwa Jacinta Mwangi. Nimesikia kwamba mwezi nifungie nje because the theme is having burden with cancer disease. Na niko na very big burden mimi. Mume wangu alikuwa mgonjwa for 3 years, alafu akakuwa akitibiwa hospitali kadhaa. Dakika ya mwisho, wakati marafiki, wakati watu wa nyumbani wote wamechoka, ndio anakuwa diagnosed ati akuna cancer stage 4. Nikatumwa KU. On October akatibiwa, December akawa discharged. Na niliwaambia kwamba mimi nimetibiwa kila mahali, sina hata ile registration fee ya kuregister. Wakamuadmit, wakaniambia nitafanya harambee. Nimefanya WhatsApp group 4, hazijawahi make it. Juu mtu akituma sotano ni ule tu ametusaidia awali. Nikawaambia kwamba waweze tu kunitolea. Wakaniambia SHA imetoa kile kiwango imetoa, na mimi ni lazima nilipe. Nikawaeleza the whole story, nikawaanzia kule kote nimekuwa nikitembea. Mume wangu amefanyiwa operation, amefanyiwa MRI mara 2, amefanyiwa biopsy, amefanyiwa hizo zote, but hawakuwa wanapata cancer. Dakika ya mwisho ndio wakaniambia ni cancer after having PET scan, wakasema iko all over the body, but nashukuru madaktari, for now ako well, but hawezi toka hospitali. Nifanye nini? Na marafiki walinitenga, watu wa nyumbani walinitenga. Nimekaa hivi tu mimi na yeye ndio nang'eng'ana na yeye, na siwezi mtoa hospitali. Sasa inaenda miezi 2 tangu dischargiwe.
Ndo masuala ambayo tunayazungumzia, na mtazamaji, ni swala la kugusa nyoyo zetu. Tunapozungumzia mzigo wa saratani, najua kilio chake kimeweza kusikika na mambo yatakuwa shwari tukimtumainia Mwenyezi Mungu. Mtazamaji, ndo shughuli nzima ambayo tumekuwa nayo, na ni vyema tukufahamishe kwamba pia tumekuandalia makala ambayo utakuwa unayatupia darubini na jicho lingine, ili uweze kuona maisha yalivyo, mzigo ulivyo wa saratani humu nchini, makala ambayo yameandaliwa na mwandishi wetu wa masuala ya afya na sayansi Elizabeth Atieno, na ndo ambayo tunakuacha nayo. Wanakwetu wananiita Joash Onsare, mwenzangu
Linda Alela,
na mwenzangu pale upande wa pili Sheilar.
Chelangat.
Asante sana mtazamaji, usiku mwema, na tuzidi kushirikiana katika kupambana na vita hivi vya saratani. Kwaheri kwa sasa, tupate makala.